In the previous class, we discussed about the lipoproteins metabolism. We discussed LDL metabolism, we discussed VLDL metabolism and HDL metabolism. Okay? Now, today we are going to discuss another important lipoprotein molecules called chylomicron. As you already know that we can differentiate the lipoprotein molecules on the basis of their content. On the basis of their content which we have. Just like that, LDL molecule contain total cholesterols. Okay? And other lipoproteins molecule contain triglycerides and cholesterol in the form of cholesterol esters. Okay? So these cholesterol are generally present in the body in the form of two basically form, cholesterol and cholesterol esters. Okay? And the major function of these lipoproteins molecules are for the transportation of exogenous dietary lipids and endogenous dietary lipids. Students, you have to understand what is the meaning of exogenous and what is the meaning of endogenous. In the exogenous dietary lipids means when we take the diet food which contain lipids, which contain cholesterol. For the transportations of these lipid molecules in the blood to different organ is known as exogenous transportations of lipid molecules, and for this transportation of this lipid molecule what we required? We required chylomicrons. Okay? But when these molecules are synthesized in the body, when triglycerides synthesized in the body, then for this endogenous triglyceride transportation, we required VLDL, IDL, chylomicrons, VLDL, LDL and HDL. Okay? Now we are going to start the metabolism of chylomicron. Chylomicron. As you already know, it is same as the metabolism of LDL. There are 4 steps already in the LDL metabolism, same as there are 4 steps in the metabolism of chylomicron. The first step is formation of nascent molecules. Okay? These chylomicrons are majorly synthesized in the intestine. In which portion of the body? In small intestines. Okay? And within 1 hour, these chylomicron molecules become metabolized in the body. Okay? Uptake by the liver and all the function of these regulatory mechanisms are proceed within 1 hour. Okay? So the first step is formation of nascent molecule. Formation of nascent molecule. Nascent stands for new molecules. Okay? And the second one is maturation of chylomicron. Maturation of chylomicron. Maturation of chylomicron. Okay? And the third step is after the metabolism, chylomicron remnant. Chylomicron Remnant, R-E-M-N-A-N-T, chylomicron remnant. Remnant, the terms you understand, the meaning of chylomicron. Remnant means the remaining portion of the chylomicron. So student, you have understand that the function of all these lipoproteins and the major function of all these lipoprotein is what? It is transport the lipid molecules and provide cholesterol and TG to the peripheral tissues, to the renal medulla, to the cardiac muscles, to the adipose tissues. Okay, these are the major function of this lipoprotein, major function of this chylomicron. But there is only a 80% absorption of these chylomicron molecules are absorbed in these peripheral tissues. Okay, so on behalf of that, there is 20% of these chylomicron are remnant. Remnant means बचा हुआ, ये बचता है इतना molecules, there is remnant molecules, that's why it is called chylomicron remnant, which is further used for the formation of new nascent molecules. Okay, and the fourth one is uptake of chylomicron by liver. Uptake of chylomicron by liver. As we already discussed, that when you see the structure of this chylomicron, what you see, that it contains a layer of phospholipids, okay, and there is a presence of cholesterol, and there is the presence of triglyceride. And how it is differentiated from others? It contains different types of proteins, different types of apoproteins, okay, different types of apoproteins, which is apoprotein A, apoprotein C, apoprotein E, and apoprotein B48. As I tell you before the class that these apoprotein, these special class of proteins are mainly synthesized from rough endoplasmic reticulum and smooth endoplasmic reticulum by the process of central dogma. I think you listen the term central dogma, that is transcriptions in the molecular biology sections. Okay? From this process, these special class of proteins are formed. And this is the structure of chylomicron. And the outer layer is formed by the which layer? Phospholipid layer. Okay? Now this is the general structure of the proteins. Now firstly, there is a formation of this is the small intestines of the body, which contain, you are forming here a molecules which contain cholesterol and TG in the inner layer and contain a special class of protein called ApoB48. ApoB48. So this is called this is called the nascent molecules. This is called the new molecules. Why? Because it contains only one class of proteins, one class of apoproteins in the outer layer attached with that. Okay? And why it is called chylomicrons? Chylomicrons means it is drained from the lymphatic vessels. Understand? It is synthesized in the small intestines and its drain comes to the blood from lymphatic vessels. Lymph stands for chyle. Lymph means chyle, chyle. Okay? Understand? That's why it is called chylomicron. That's why it is called chylomicrons. Okay? So here it contains B48 protein and ApoA. Apoproteins, you understand that the meaning of, what is the meaning of ApoA? This is called apoproteins. You know what is the meaning of apoproteins? It is like enzymes, holoenzyme, apoenzyme, the cofactor which is attached with that. Okay, same as these words comes, that these apoproteins are attached with these molecules and they also participate several functions. Several functions. We already discussed what are the function of these apoproteins. These are generally used to activate some of the enzymes, to inhibit or suppress the activity of the enzymes. Okay. Now this is the nascent molecules. After that the nascent molecules, there is the formation of new molecules. Maturation, mature hoga. Because here the birth of this molecule occur from the small intestines by the lymphatic vessel. It comes to the existence and it contains some of the class proteins. But how it is mature? It is mature by the attachment of some more class of proteins. Have you seen the structure of apoprotein, which I draw you before? That in the chylomicron molecules, it contains some special class of protein, that is ApoC and ApoE. ApoC and ApoE. And here, these molecules contain triglyceride and cholesterol esters. The first protein called B48 and second protein called ApoA, ApoC and ApoE. Now this molecule mature. Mature means now it comes in the existence well and it go for further next functions. Okay. Now we call these terms mature of chylomicron. Okay. Triglyceride, cholesterol is present in two forms, either cholesterol or in cholesterol esters. But here it is present in the form of cholesterol. Okay. Now question comes here, how these apoproteins are come? Which one? ApoC, ApoE. How these apoproteins are come? Okay. So it is correlated with the HDL molecules. HDL molecule can donate their special class of protein for the transportation of these exogenous triglyceride. Okay, this is the molecule of HDL which contain phospholipid, okay, which contain cholesterol and having a special class of proteins we call ApoC, ApoE, okay, ApoC, ApoE and ApoA. This is the HDL molecules. HDL stands for high density lipoproteins. They can donate their special class of protein, both these proteins, to which molecule? Nascent chylomicron. Okay. So now after the giving these molecules to the chylomicron, there is a formation of mature of chylomicron. This is the second step of this metabolism. Okay. Understand? Very simple. It is synthesized from the small intestines. In the small intestines, there is the presence of a particular kind of rough endoplasmic reticulum and smooth endoplasmic reticulum. What they do, they forming some special apoproteins molecules. Here, it is firstly come into the lymph, and from the lymphatic vessel it drainage to the blood. Okay. So there is a forming of nascent molecules. So what is the difference between nascent molecules and mature molecules? They contain less apoprotein rather than mature proteins. Okay. Now from this, the next step is these molecules goes to the extrahepatic tissues or peripheral tissues, or from the cardiac muscles to the muscles, renal medulla and some other cells. Why? Why it is goes to the other tissues of the body? For the transportation of triglyceride. Okay, for the transportation of triglyceride. But students, there is a one thing, that one important enzyme, we call the enzyme lipoprotein lipase. What we call? Lipoprotein lipase. And the lipase having the activity of hydrolysis. Lipase having the activity of lipolysis. Okay, breakdowning those molecules. These lipoproteins lipase molecules are generally present in the blood capillaries. Okay, it is attached with the interior wall of this blood capillaries. Okay, when this comes with the reaction with these molecules, they can, what they change, what is the effect of this LPL on these molecules? They can break down this TG. They break down this triglyceride molecules into, firstly it break down triglyceride into diacylglycerol, DAG, and in the next step it break down into monoacylglycerol. DAG, triglyceride firstly break down into diacylglycerol and lastly into diacylglycerol, monoacylglycerol. TG, triacylglycerol break down into diacylglycerol, that it contain 2-glycerol fatty acid, and lastly it contain MAG, monoacylglycerol, and it finally break down into glycerol plus free fatty acid. Free fatty acid. How it is break down? By the activity of LPL, by the activity of lipoprotein lipase, which is present in the blood capillaries. Okay, and it is activated by this enzymes B48. Understand? When the enzyme are contact with this apoprotein B48, they become activate. And what happens? When they activate, they can further metabolize these molecules and they converted this internal Tg into all these breakdown molecules, glycerol and free fatty acid, glycerol and free fatty acid. ओके यहां तक क्लियर हुआ? अब देखो, now in the next step there is the molecules we call this as extrahepatic tissues or peripheral tissues. What we call extrahepatic tissues or peripheral tissues. It is renal medulla, it is cardiac muscles, okay. All rather than hepatic tissues, it is called peripheral tissues. So now these molecules, it breakdowns, these molecules now break down into free fatty acid. Free fatty acid, we call this as adipose tissues. Adipose tissues. Okay. Now these molecules are break down with the activity of LPL into it forming glycerol. Okay. It forms free fatty acid, which is go and deposit in the adipose tissues. In the adipose tissues. Okay. Understand? These can be stored in the adipose tissues. What is the function of adipose tissues? What is the function of adipose tissues? Yes, it stored lipid molecules, and during starvation condition, during uncontrolled diabetes mellitus condition, okay, in this condition, they provide fats to the body. Okay, they provide fats to the body for further energy production. वो कहता है ले जाओ फैट, बॉडी पे जब ग्लूकोज यूटिलाइज नहीं हो पाता, when the glucose is not utilized for the production of energy, then what they do, these adipose tissue can donate their free fatty acid for further production of ATP by different metabolic process like beta oxidation. Okay, so adipose tissue can take free fatty acid. First, here glycerol molecule is separate out, and all these process there is 80% of chylomicrons are used. %80 chylomicrons are used, and remaining molecules are which having some Tg and some cholesterol, which contain some of the proteins here attachment with that. We call it B48 and ApoE. Okay, now you will see the size of these molecules. These contain high amount of Tg and cholesterol, but after the process of lipoproteins lipase, which is generally present in the blood capillaries, okay, these can reduce their size because they give all the triglyceride and cholesterol molecules to the extrahepatic tissues, and there is 20% remaining molecules are remain, which we called remnant chylomicron. Understand? Which we call remnant chylomicron. This is being the third step. What is that? This is the third step of chylomicron absorption. Now here, which one is the last step? Very good. Uptake of chylomicron. So now, what is this? Liver. Okay? And this is a receptor which is present in the liver. And student, this is a regulatory mechanism process. Understand? Chylomicron molecules are fated in the metabolism process and it can form very earlier. Okay? So, and this we call, these are the receptor we call LDL protein receptors. What we call LDL receptors? This is LDL receptors and this is LDL related protein LDL related protein receptors. Okay? So, this is present and here one important another enzymes are present which we call HL. HL stands for hepatic lipase. Okay? So, what is the activity of hepatic lipase? They can act on this triglyceride molecules and these apoproteins can recognize these receptors and these molecules break down first and these can go further uptake process. Uptake process in the liver. So, what is the function of liver? They can metabolize the cholesterol and fatty acid. Okay? They can take the cholesterol molecules first and they also take TG. But here by the activity of this hepatic lipase they again break down into monosylglycerol, disylglycerol and it can comes in the form of free fatty acids. Free fatty acid. This being the last step of chylomicron metabolism. Understand? It is very simple to understand. There is no rocket science. First one is formation of a new molecules. Okay. Second one is maturation. Very good. Third one is remnant of chylomicron and fourth one is uptake. So here metabolism process is over. Now we discuss another important clinical condition called fatty liver. This is our liver, okay, and they contain several enzymes for the breakdown of sublipid molecules. But in some of rare condition, what happen? There is depositions of the lipid molecules. The lipid molecules can accumulate here and this can change the outer layer of this lipid, making the fibrosis, of the lipids by the accumulation of the fat molecules, by the accumulation of mainly triglyceride, okay, and they can produce many other symptoms like hepatomegaly, that is enlargement of the liver, hepatomegaly, okay. If reason is pronounced, we can causes hepatitis, cirrhosis, and hepatic failure. Hepatic failure. Okay. So, fatty liver, that's a condition in which triglycerides accumulate in the liver and they causes some chronic fibrotic changes in the liver outer layer. Okay. And due to this, patient having these all symptoms, hepatomegaly, hepatitis, cirrhosis, and hepatic failure. Okay. So I already discussed that. What is the function of the lipid? It is the main center for the metabolism process. First one. Okay. If the molecules are not metabolized properly, they can produces some fibrotic changes. Okay. But it is mainly two types. But it is mainly of two types. The first one is student write it, non-alcoholic steatohepatitis. We call this condition NAS, non-alcoholic steatohepatitis. What we assume? We assume that liver is always spoiled by the drinking of more alcohol. Generally यही कहा जाता है कि by the taking of chronic alcoholism, the liver may damage. But it is not like that. Okay? There are several reasons. The first one is non-alcoholic steatohepatitis, that is, which is by chronic inflammatory fibrotic changes. Okay? How this condition occur? This is a condition by the deposition of the cholesterol triglyceride in the liver, which can changes fibrotic changes. And due to this, these non-alcoholic steatohepatitis occur, and due to continuous this, there are several symptoms or comes, which we discussed before: cirrhosis, hepatocarcinoma, and liver failure. Okay. When accumulation of the lipid in the liver become chronic, fibrotic changes in the cell may finally lead to cirrhosis and impairment of the liver functions. So what is the function of liver? This is the main site for the metabolism. Okay. If there is fibrotic changes may occur, there is more deposition of free fatty acids, and these free fatty acids are not generally used. Okay. Fatty liver is a condition there is an imbalance in the hepatic triglyceride synthesis and secretion of VLDL. It is mainly categorized into two main categories. Okay. You understand both of these categories? The first type is that it increases the level of plasma free fatty acid. Increase the level of plasma free fatty acid. How this increase the level of plasma free fatty acid? Because these lipoprotein molecules contain TG and it is converted into Which one? Hepatic, by the activity of lipase enzyme, it is converted into free fatty acids. And these free fatty acids are going to which organ? In the liver for the further metabolism. But if there is accumulation occur, if there is hepatocytes not well, there is fibrotic changes may occur, there is increased level of plasma free acids. They are not metabolize the free fatty acids. Okay? The increased amount of free fatty acids are taken up by the liver and instipated to triacylglycerol, but the production of VLDL does not keep pace and increased influx of fatty acid, which allow triglyceride to accumulate, which is turn causes fatty liver. So student, understand, in the liver, these free fatty acids is converted into synthesis of this TAG, triacylglycerol. Okay, triacylglycerol. And when there is a more process occur, there is a blockage of this process, there is accumulation of this fatty liver. Or it is mainly occurring in starvation and high fat diet. This is the main two reasons. The second type, where the improper functioning of plasma lipoproteins, and these all are the cause. The first one is blocking of lipoproteins molecules, blocking apolipoprotein synthesis. Okay, a block of synthesis of lipoprotein from lipid and apolipoprotein, defect in the synthesis of phospholipids, and failure in the secretory mechanism itself. Because liver having several functions, they can metabolize the molecules there as a excretory organ of the body. Okay, so if there is fatty liver occur, there is fibrotic changes may occur, they leads to accumulation of these molecules. If the lipoproteins are not function well, what are the main function of lipoprotein? They can transport the cholesterol and triglyceride molecule to the extrahepatic tissues, and from extrahepatic tissues it takes the cholesterol and TG like HDL, it takes to the liver for further metabolism. If these lipoprotein molecules are not formed, how these lipoprotein molecules are formed? By the attachment of some apoproteins. If the synthesis of these apolipoproteins are blocked, like ApoB48, ApoC, ApoC second, ApoE, if it is not synthesized, these molecules are not synthesized. The synthesis of lipoproteins are not occur. If it is not synthesized, there is no transportation of this. TG molecules from the liver. And what happen on this condition? These TG become accumulate in the liver, and again fibrotic changes may occur. These are the cause of fatty liver: high fat diet, in uncontrolled diabetes mellitus, in alcoholism, high cholesterol diet, use of certain chemicals. Okay, and the main symptoms you see in such kind of patient is patient when the liver is not function well, what happen? There is increased level of bilirubin in the blood. All the enzymes in the liver are disorientated and they not functioning well. The liver is not functioning well. The patient becomes what the condition arise? They having pallor. Pallor means dollar pallor, inflammation types. Okay, so it is pale in color. But the yellowish color you will see on the retina of the eye. Dietary deficiency, these are the lipoprotein factor, the choline, betaine, methionine and lecithin. These are lipotropic factor. What is the lipotropic factor? The factor which can prevent the liver to become fatty is called lipotropic factor. They can prevent the liver to become fatty. It is known as lipotropic factor. These questions generally ask in your viva, what is lipotropic factor? So you will tell this is some certain component which can defend the liver to become fatty. Okay, some essential fatty acid, essential amino acid, and in the case of protein deficiency and kwashiorkor. Okay. Now lipoprotein factor accumulation definitely by the It can reduce the deposition of the fat in the liver. If there is regular deposition, the liver become fatty. These all are the causes, and all your vitamin B12 and folic acid also lipotropic factor, because these involved in the formation of methionine and homocysteine. Okay. Now, students, our these are completed. Fatty liver is over. Now we see some diseases. Lastly, and we complete this, finish this topic within a few minutes. Hypolipoproteinemia, that means there is low level of lipoproteins in the blood, and the causes are a beta lipoproteinemia and the Tangier disease. Primary hypolipoproteinemia is due to reduced synthesis of proteins. Here we talk about apoproteins. Here we talk about the special class of protein which is attached with the outer layer of this lipoproteins. Okay, if the protein is not synthesized, the level of this lipoprotein become reduces. It is in the case of a beta lipoproteinemia, Tangier disease. Secondary hypolipoproteinemia is in the case of Kwashiorkor, severe malabsorption, and in CLD, in the chronic liver disease. Understand? A familial hypercholesterolemia. Familial hypercholesterolemia is what? The enzyme, if there is genetic label or occur for the formation of this lipoprotein molecule, hypercholesterolemia is a genetic disorder caused by the mutation of LDL receptor genes. When here is defect in the gene, then it causes the hypercholesterol due to absence of functional receptor of LDL like B100 and ApoB100 and ApoE. Okay? Understand? If there is LDL molecules are not synthesized, so what happens? There is no transportation of the cholesterol, because LDL contain 100% cholesterol molecule inside them. Okay? So that leads to hypercholesteremia, high level of cholesterol. High level of cholesterol means more than 200 mg per dl. Okay? So these all are the disease which is related with that. Now all of you read this and make nephrotic syndrome, hyperthyroidism, chronic renal failure, alcohol abuse, diabetes mellitus, and use of contraceptive drug. These are all are the causes of secondary hypolipoproteinemia. Okay, now we finish this topic today. We started with the next topic in the next class. Thank you.
We discussed about the some common properties of hormones. Like number one was there was some primary, secondary, and tertiary part. Primary means damage of the gland, gland problem. Suppose thyroid. Secondary means pituitary, একটু উপরে গেল, and tertiary means hypothalamus. In this way, number one, number two, hormone is active only in free form. Blood আছে, the blood free hormone is active, otherwise not. Then other points, এবার তোরা বলবি পড়েছিস কি আদৌ না? বল না, ভুল বলতে বল। পড়েছিস? বল। তাহলে না পড়লে কি করে পরেরটাই যাব? হরমোনের ক্রাইটেরিয়া, তাহলে নন স্টেরয়েডাল হরমোনস কারা? হ্যাঁ, পেপটাইড হরমোনস, হ্যাঁ, প্রোটিন। ওকে, হাউ দে অ্যাক্ট, কিভাবে কাজ করে? রিসেপ্টর is present where? Cell membrane. Very good. And steroid hormone জন্য receptor intercellular, that may be cytoplasmic as well as internuclear. Good, fine, fantastic. Do you remember any example of steroid hormone? Estrogen, progesterone. Any others which acts like a steroid hormone? Vitamin D, right? Thyroid hormones. These act through like steroid hormones. So now in the previous class it was discussed that the hormone that is a non-steroidal, it acts on the receptor first, ligand gelo, then what happens? The receptor is coupled with G protein. G protein has three segments: alpha, beta, gamma. Then beta or gamma will be out after the attachment. Then the connection to the GTP. Then this GTP connected alpha unit activates the enzyme. Which enzyme? Adenylate cyclase. And these adenylate cyclase activations forms secondary CMP, cyclic MP, secondary messenger, right? Then where is the primary messenger? Primary messenger K? Hormone. Very good. So hormone is a primary messenger, secondary messenger is cyclic MP. What is the role of cyclic MP? It activates protein kinase A. Very good. Kinase means phosphorylates some enzyme toward further cellular functions. So this activates protein kinase A, and then it phosphorylates different types of proteins, and then its activation as a cellular response. A steroid কি করে is forms hormone receptor complex and then bind to a specific region of gene DNA that is called hormone responsive element, right? This hormone responsive element is a transcription factor, is causing the transcription, formation of mRNA, then translation, then the protein, the required protein that is essential for the further cellular response. মানে আমি প্রোটিন একটাতে তৈরি করতে চাইছি আর একটাতে ফসফোরিলেশনস করে বিভিন্ন কাজ করতে চাইছি। That may be some ion channels that must be open after the phosphorylation. That is the action of the cyclic MP, protein kinase A activity, phosphorylation, and then incorporations. Finished? Now, we already know that hypothalamus is a key CEO overall. But in the hypothalamus, there are different types of nuclei. Nuclei means collection of neural cell bodies, right? So if we draw this is a hypothalamus, এর আগে আছে thalamus in the forebrain, right? This is a stalk, infundibulum বলা হয়, অ্যানাটমিতে কিছু কিছু হচ্ছে তো নাকি? And then this is a pituitary gland, and this is the anterior pituitary and this is the posterior pituitary. কেন? এটাও তো হতে পারে স্যার। You may ask questions that maybe এটাও হতে পারে স্যার, আমি বললাম এটা anterior এটা posterior, কে বলেছে hard and fast? That is a rule. What rule? There is a presence of some optic chiasma, and here is a presence of mammillary body. It is a mammillary body. This is the anatomical part. This is not, we will not go beyond this. So whenever is the optic means front. Optic means front, means this side is the anterior part of it. এবার আর কিছুতেই বলতে পারবে না। You can't say anything about that. Yes sir, I can say that. If that is not present, then you can say this anterior, this posterior. কে বন্ধ হয়েছে? No. So this is the optic chiasma, anterior pituitary, mammillary body, posterior pituitary. Now, what is the other name of anterior pituitary? Adenohypophysis. Adenohypophysis. Okay. Then this is the adeno. What do you mean by adeno? Anyone? Huh? Glands. Very good. Adeno means glands. That means here different types of glands will be there. Different types of glandular cell will be there. Different types of glandular cell will be there. Different types of glandular cell will be there. And this is called neurohypophysis. Neurohypophysis. Hypophysis. Neuro. means nerve. Means this hypothalamus extension is a part of posterior pituitary. So here is a cell body may come like that, and this is a neuronal part. Another important term is that portal system, hypothalamo, hypophyseal, portal system. Blood to lagbe. Hormone ke carry korte gele blood lagbe. So these are the present in both area. Mainly is a present in the anterior part. Okay. So this is like a vessels with capillaries. Portal system means two capillaries will be there. Two capillaries will be there. That some capillaries may present here is the capillaries, and some capillaries may present in the this area. So these two capillaries form any types of portal circulations. So this means hypothalamo, hypophyseal, portal system. Well, up to this kiki signal, adenohypophysis, some glands are there in the anterior pituitary. Posterior is an extension part of the hypothalamus. There is a neural part, and this neural part means is connections to the neurally. I'm coming later what is happening, and this another term is a hypothalamo, hypophyseal, portal system that is essential for carry the hormones ke chai. Now, in the hypothalamus, there are some nuclei. অনেক নিউক্লিয়াই আছে, আমি তোদেরকে ডিটেলসে গিয়ে আমি বোর করব না, বাট স্টিল আমি কয়েকটা নিউক্লিয়াস বলবো, তার কারণ এগুলো দরকার আছে। সাপোজ দিস ইজ এ কালেকশনস অফ সেল বডিজ, is a nucleus. Number one nucleus is a paraventricular nucleus. Number two is suppose এরকম টাইপের একটা দেখতে, আমি এটা বোঝাবার জন্য বলছি, and these are the preoptic nucleus. This is preoptic nucleus. Suppose there is another, here is a nucleus, is a collections of cell bodies, and so this nucleus is coming. That nucleus is called arcuate nucleus. So up to this paraventricular, preoptic, and then arcuate. Supraoptic nucleus. This is called supraoptic nucleus. চারটে নিউক্লিয়াস বললাম, তাই তো? সুপ্রাঅপটিক, প্রিঅপটিক, প্যারাভেন্ট্রিকুলার, আর্কুয়েট। আর অনেক নিউক্লিয়াস আছে। We will go day by day, we will came across the nucleus of the hypothalamus. Ventrolateral nucleus, dorsomedial nucleus, lateral nucleus, anterior nucleus, everything is there. যেমন ventromedial controls our satiety. If any lesion of that nucleus causing the obesity, কেন? satiety সেন্টারটা খারাপ হয়ে গেছে, খেয়েই যাচ্ছিস, হতে পারে। আবার ল্যাটারাল নিউক্লিয়াস, সেটা কি না, হাঙ্গার, খিদে পাচ্ছে আমার, সেটা কে কন্ট্রোল করছে? ল্যাটারাল নিউক্লিয়াসটা নষ্ট হয়ে গেছে, খিদে নেই, রোগা পাতলা, অ্যানোরেক্সিয়া নার্ভোসা, হ্যাঁ, ম্যারাসমাস, একটা ম্যালনারিস্ট, খিদেই পায় না তার, একটা দিক আছে ভেন্ট্রোমিডিয়াল গেল, তখন খেয়েই যাচ্ছে, তার কোনো স্যাটাইটি সেন্টারটা অ্যাক্টিভ নয়। স্যাটাইটি মিনস কি? whenever you are taking any food, একটা জায়গাতে খেতে গেছিস, খেতে পেট ভরে গেল, does not mean যে হয়ে গেল, পেট ভরে গেল, that means that the stretching or information is going to your ventromedial part of the nucleus of the hypothalamus, and they are telling that don't get any other further food. I am satisfied, don't take this. তাও যদি মনে হয় তোরা একটু খাবি, আরো 2 চামচ 3 চামচ খেতে আলটিমেটলি আর খেতে পারবি না, খেতে পারতে পারিস না। বাট এটা যদি দেখা যায় এবার চলে গেছে, খেয়েই আছে আরো বেশি, মানে ওই স্যাটাইটি সেন্টারটাই তার খারাপ, দ্যাট মিনস হি অর সি মে গেট obesity চলে আসে, morbid obesity. Okay, lateral hypothalamus, in this type lateral nucleus is there. Remember at this point that there are different types of nucleus in the hypothalamus there. They collect the information from outside, they collect the information from the outside. I am giving an example. Suppose you are dealing with the examinations and you are in stress. You are in stress. আমরা বললাম এই সিলেবাস আছে ফার্স্ট সেমিস্টারে, ইউ আর ইন স্ট্রেস। কি বলবে স্যার, কোশ্চেন করবে, কি পাস করবো ফেল করবো, দিস ইজ গোয়িং অন অ্যান অ্যাংজাইটি অ্যান্ড স্ট্রেস। দিস স্ট্রেস acts as a secondary triggering factor for the paraventricular nuclei. Now the question arises, that means এখানে স্টিমুলেশন করলে কিছু হবে না, that means some sorts of releasing and inhibiting hormones are coming. So remember, from hypothalamus, releasing hormones and inhibiting hormones are coming all the time. That does not mean sequentially giving, inhibiting and releasing. No. Whenever it is requirement of releasing, then they are releasing. Whenever requirement of inhibiting, then inhibiting. Inhibiting mainly releases after the negative feedback. One of the important criteria was there of hormone, that is a feedback mechanism. Most of the mechanism of our feedback mechanism are negative feedback mechanism, except few are the positive feedback style. So this paraventricular nucleus is getting a stress, and then stress stimulates the paraventricular nucleus to release the corticotropic releasing hormone. And this corticotropic releasing hormone then comes to the hypothalamo hypophyseal portal system. এখান থেকে কিছু হরমোন বেরোলো, নিয়ে এখানে চলে এলো। That is coming to this way, and this way now already told that is adeno means some glands are there, some glandular cells are there. So cells name are the different. Cells name are different. Suppose this is called somatotroph. This is called somatotroph. This is called thyrotroph. This is called gonadotroph. TROPE. This is called lactotroph. So what is happening here? There are some glandular part and some names are there. That is specific for the action of some specific releasing hormone for that name. Suppose I am telling stress stimulates this one, paraventricular nucleus. Okay? Then paraventricular nucleus releases two releasing hormones and inhibiting hormones as well. What are those? One is the corticotropin releasing hormone. One is এখান থেকে বেরোচ্ছে number 1 corticotropin releasing hormone. Number 2 is a TRH, that is thyrotropin. Releasing এর আগে always utter the term tropin, TROPIN. In this way, these releasing hormones are coming from the paraventricular after the getting the secondary triggering factors. Secondary triggering factors may be fever also, that may be hypoglycemia also. So every nucleus is get triggering factors for specific nuclei, has specific triggering factors. I mean coming later, but still stress corticotropic factor কোথায় আসবে, এখানে কাকে স্টিমুলেট করবে? Another cell is corticotroph. আমি ভাবলাম তোরা বলবি, বাট বললি না, তার মানে পড়িস না। Corticotroph are the another gland. Then these will come, these hormone come here, and then this is stimulated to release ACTH. কেউ একটা বলেছে, ভেরি গুড। সো মুখ থেকে কথা বেরোচ্ছে, ACTH will come. কোথায় যাবে বাবা? এটা অ্যাড্রিনাল কর্টেক্স। অ্যাড্রিনাল কর্টেক্স থেকে কি বেরোয়? হ্যাঁ, গ্লুকোকর্টিকয়েড, মিনারেলকর্টিকয়েড, অ্যান্ড্রোজেন্স। কি অ্যান্ড্রোজেন্স? দেন বেরোয়, অ্যান্ড্রোজেন্সই বেরোয়। অ্যান্ড্রোজেন্স বেরোয় যেটা, দ্যাট ইজ স্পেসিফিক ফর দ্য ফিমেল মেনলি। Androgens releases from the adrenal cortex is mainly related for the female, not for male. Now, ACTH and this cortisol release কর্টেক্স থেকে কি বের করবে? কর্টিকোসোল। সেটা কি জিনিস? গ্লুকোকর্টিকয়েড, কর্টিসোল। So cortisol is a releasing ultimately after the stress. বোঝা গেল? মন না দিলে বুঝবি না, পরিষ্কার। So there are some nucleus in the hypothalamus. They are releasing or inhibiting some hormones after getting the secondary triggering factors. Secondary factors may be anything, fever, hypoglycemia, stress, that may be other breastfeeding, other nuclei, for the other nuclei, breastfeeding, pregnancy, cold, anything, amino acid high, fatty acid low. These are the triggering factors from outside. We already told that hypothalamus is an integration center for the hypothalamus, a endocrine system and the neural system, right? So any information must come in the hypothalamus first, and then they will release the releasing or inhibiting hormone whenever it is required, and then after that it goes through the portal system and then specific for the specific. Suppose paraventricle থেকে আমি এখানে CRH বের করলাম, মানে কি এটা? From here also TRH also released. এখান থেকে আবার TRH ও রিলিজ হয়। এই যে লিখেছি এখানে TRH। সে কি করবে? He will come in the portal system, then কাকে স্টিমুলেট করবে ভাই? হ্যাঁ বল, নাম তো লেখাই আছে, সোমাটোট্রোপ লেখা আছে, থাইরোট্রোপ লেখা আছে, গনোডোট্রোপ লেখা আছে, ল্যাক্টোট্রোপ লেখা আছে, কর্টিকোট্রোপ লেখা আছে। কাকে স্টিমুলেট করবে? থাইরোট্রোপকে স্টিমুলেট করবে। সো দিস উইল কাম এন্ড দেন अगेन স্টিমুলেট দিস ওয়ান টু রিলিজ কি? থাইরয়েড স্টিমুলেটিং হরমোন। কোথায় যাবে? থাইরয়েড গ্ল্যান্ডে যাবে। কি রিলিজ করবে? T3 and T4 ফর দ্য ফার্দার। কথা বলবি না, লাস্ট বেঞ্চ। হ্যাঁ ইউ সামনে চলে আয়, সামনে আয়। This thyrotrope is for the TSA release. Gland T3 T4. In this case, if T3 T4 is high amount, খুব বেশি অ্যামাউন্ট কি করছে, বেড়ে গেছে, দেন নেগেটিভ ফিডব্যাক। সে কি করবে? সোজা গিয়ে একে আগে নেগেটিভ করে দেবে, TSH কে নেগেটিভ। ভাই তুই থাম, আমার এত দরকার নেই। আবার এইটা চলে যাবে একবার এইখানে প্যারাভেন্ট্রিকুলার নিউক্লিয়াস টু inhibit the paraventricular nucleus to restrict the release of thyrotropin releasing hormone. Why do you থাম? Because thyrotropin hormone, then TSH, then T3, T4. In this way, total, you have to understand what is going on and what is the going to the target, before the target tissue, what is going on inside our brain. One of the clinical scenario I am giving for you, interesting. There is a patient, suppose একটা চাইল্ডই ধরি, কারণ এই চাইল্ডটা আমারই ছিল পেশেন্ট। এ পেশেন্ট হ্যাভিং 10 years of age, একটা গার্ল চাইল্ড from our nearby, that is Asansol. A patient come with having loss of vision, sudden onset loss of vision, nothing or other than কোনো symptom নেই, just come for loss of vision. স্যার আমার ভিশন চলে গেছে। আমি বললাম ভিশন চলে গেছে, তুমি চোখে কাজে যাও। আমি তো এটাই বলবো। After they come in from the checkup, they are seeing that eye specialist telling that something is going on in the brain, so that optic nerve, optic chiasma compressed. I simply do a MRI and seen that is a huge pituitary adenoma. That is huge pituitary adenoma, or simply benign pituitary tumor is there. If so, suppose এখানে একটা পিটুইটারি গ্ল্যান্ড আছে, এইটা এত বড় হয়ে গেল যে পুরো এখানে যে অপটিক কাইজমা বা অপটিক নার্ভ আছে তাকে কম্প্রেস করছে। These are compressing without any other symptom that may happen. তার মানে because these are nerve, এখানে তো নার্ভ গেছে, অপটিক নার্ভ is there, This is compressed. If optic nerve is not functional, then how can I see? How can the girl can see? So presentations may become with only the loss of visions due to this pituitary tumor. Now, this pituitary tumor are two types are there. One is a simple benign enlargement of the tumor. Other can be hypersecretion of the tumor. টিউমার থেকে প্রচুর পরিমাণে হরমোন সিক্রেট করছে, তার প্রেজেন্টেশন ডিফারেন্ট। যে হরমোন করবে বেশি তার মধ্যে করে হবে। সাপোজ they are releasing too much acetate. Too much acetate. If it is too much acetate, then Cushing syndrome. That may present is a Cushing syndrome. Less, that may suppress the release of acetate. কি হয় সেটা? acetate কমে গেছে মনে কর, কোন ডিজিজ? অ্যাপ্রোচ এটাই হবে, অ্যাডিসনস ডিজিজ। So in this way, you have to think not only that hormone, also in the clinical part also, that how may present patient in your emergency. So up to this কি হলো? 4 nuclei I explained. That is the preoptic, supraoptic, paraventricular, arcuate. We focused on only the paraventricular nucleus to release the thyrotropin releasing hormone and corticotropin releasing hormone. The releasing hormones are coming after some triggering factors, getting some triggering factors from outside and the stimulation of the nuclei. Nuclei means some collection of the cell body, nothing else. So these releasing hormones comes into the portal system to stimulate the specific gland. If it is corticotropin releasing hormone, then it is stimulate the corticotrope. If it is thyrotropin releasing hormone, then it stimulates the thyrotrope. So in this way, they activate to release the further hormone, that is thyroid stimulating hormone, and as well as acetate from the pituitary. Right? Now, after that, it goes to the target cell বা target organs. acetate এর জন্য target organ কে আছে? target হচ্ছে কিডনি, মানে adrenal gland. Adrenal gland কোথায়? না cortex. So this cortex will release the different types of cell layers are there. The details will be discussed in the another class. That is the glucocorticoid, mineralocorticoids. The glucocorticoids will release them through the cortisol. Cortisol is important for our stress, all we know. আমাদের যখন স্ট্রেস থাকে তখন cortisol level বাড়ে. Simply, nothing else. In this way, in case of Cushing syndrome or Cushing disease, this acetate level is high. So these are high level of cortisol. Presentation will be key. Moonfish, buffalo hump. Between the solar and fatty lump is there, weakness, stria. These are the symptoms of Cushing syndrome. Cushing syndrome আমি 2-1 দিন আগে একটা পেলাম বাচ্চা, আমি সাসপেক্ট করেছি এবং ওটা বেরিয়েছে। সিম্পল একটা কথা মনে রাখিস, to diagnose the Cushing syndrome is trunk obesity will be there without any obesity of the peripheral extremities. পা হাত পা গুলো রোগা রোগা, ট্রাঙ্ক হচ্ছে মোটা। একটা বাচ্চাকে ওবেসিটি যদি আমি বলতে চাই তাহলে সাধারণত জেনারেলাইজড ওবেসিটি হবে, হাতগুলো মোটা মোটা থাকবে, সবাই সব দিক থেকে হবে। বাট ইফ ইউ থিঙ্ক, ইফ ইউ সি এনি পেশেন্ট দ্যাট হ্যাভিং দিস, বাট দিস পেশেন্ট Cushing syndrome due to the use of long-term steroid, the patient is of rheumatoid arthritis. Rheumatoid arthritis আমি যাব না, rheumatoid arthritis এর জন্য steroid treatment is a treatment. Now he is getting steroid for long run. Father and the parents is not truly educated that must be tested for every 3 months what is the level of cortisol during the long term of steroid. এই জন্য long term steroid এ যারা যারা তাদের রিলেটিভরা খাচ্ছে, be very careful to avoid the further Cushing, এটাকে বলা হয় exogenous Cushing syndrome. Exogenous, why? Because it is giving the steroid, it is not from this problem. আমার পিটুইটারি থেকে অ্যাসিডেজ বেরোচ্ছে না, আমি বাইরে থেকে কর্টিসল দিচ্ছি। That's why this causing the exogenous Cushing syndrome. That's very important. Now come to the preoptic nuclei. Preoptic nuclei থেকে কি বেরোবে? কোন রিলিজিং হরমোন? Any idea? Any idea? Gonadotropin releasing hormone. এখান থেকে বেরোবেন gonadotropin releasing hormone. সেই আবার সেই পোর্টাল সিস্টেম দিয়ে যাবে, পোর্টাল সিস্টেম দিয়ে গিয়ে কোন সেলটাকে স্টিমুলেট করবে, গোনাডোট্রোপ, ভেরি গুড, গোনাডোট্রোপকে স্টিমুলেট করলো, দেন এটা এটা কোথায় যাবে, গোনাডসে যাবে, গোনাডস থেকে কি বের করবে, গোনাডে গেল, গোনাডে থেকে কি বের করবে, FSH and LH. Now question is that one releasing hormone is coming but two is giving the gonad, but remember simultaneously both the hormone is not be released. That depends upon the frequency of the release of gonadotropic releasing hormone. মানে এখানে যে GnRH টা এসে যেকে স্টিমুলেট করলো to release the FSH gonadotrop থেকে, যেটা gonadotrop, it is not sorry, it is not gonad, gonad should be come later. So GnRH frequency not concentration, এটা আসলে ভুল করে, এই জায়গাটা একটু কঠিন আছে, but still you remember that FSH LH is released depends upon the frequency of release of gonadotropin releasing hormone from the pre-optic nucleus. That is important. If the frequency of GnRH is high, suppose this is high, only the LH will be secretion. If frequency is less, then only the FSH will come. Finish. And this FSH LH is goes to the gonads to release the key estrogen, progesterone, testosterone, etc. Otherwise, inhibin, epiendysteon, everything. So GnRH, hypothalamus, gonadotrop, not gonads, gonadotrop, FSH LH depends upon the frequency of release of this. When frequency is high, LH, when frequency is less, then FSH. Finish. Chalo. So preoptic nucleus gone. Preoptic nucleus gone. Now another nucleus I'm coming, that is arcuate nucleus. এই যে বাবু বসে আছে এখানে, এখান থেকে দুটো জিনিস বেরোবে, ওয়ান ইজ গ্রোথ হরমোন রিলিজিং হরমোন, ওয়ান ইজ, এদিকটা মুছে দিই একটু, one is growth hormone releasing hormone, another is prolactin inhibiting factor or hormone. এখানে tricky. This prolactin inhibiting hormone is also called dopamine. It's also called dopamine. It's very important. So first of all, growth hormone releasing hormone. So growth hormone releasing hormone means these are coming from arcuate nucleus. কোথায় যাবে বাবা? যাবে সেই টোটাল সিস্টেম, সেই সিস্টেমে এসে তাকে স্টিমুলেট করবে। সোমাটোট্রোপ, ভেরি গুড, সোমাটোট্রোপকে ইনহিবিট করবে, and then these will release, কি করবে? গ্রোথ হরমোন রিলিজ করবে। এ কোথায় যাবে? মাসেল বা বোন, তাহলে বোন বা আমার মাসেল। নাও এখানে একটা ব্যাপার আছে, you are seeing that some pituitary hormones goes to a target organ, then releasing the others hormone for the further action. But in case of growth hormone, it goes directly into the tissue where it acts. But in case of FSH, TSH, তারা কি করছে? থাইরয়েড গ্ল্যান্ডে গিয়ে তারপরে T3 T4 বের করছে। এ কিন্তু আর মাসেলে গিয়ে বা বনে গিয়ে আর কিছু বের করছে না, সে ডাইরেক্টলি অ্যাকশন করছে, মাসেলের গ্রোথকে বাড়াচ্ছে, বনির গ্রোথকে বাড়াচ্ছে। দ্যাট ইজ দ্য ইম্পর্টেন্ট। আই এম কামিং লেটার further part for your memorization, some mnemonic I will share. So in this way, another hormone is prolactin inhibiting hormone, also called dopamine. It comes from the arcuate nucleus, then the portal system, then which of this stimulation হবে? Lactotrope stimulation হবে কি? হবে না, নামটাই তো বলছে প্রোল্যাক্টিন ইনহিবিটিং হরমোন। মিন্স নর্মালি whenever concentration of PIH is high, PIH concentration is high, then this lactotrope will be inhibited to release the prolactin. বের করবে না। But if the concentration is low, this inhibitory gone, then it is stimulated to release the prolactin. বোঝা গেল? And this prolactin also directly goes to the breast, uterus, whenever it is needed. Again, like that growth hormone. গ্রোথ হরমোন কি করেছিল? মাসেল আর বনে চলে গেছিল। ঠিক প্রোল্যাক্টিনও তাই করলো। ব্রেস্ট টিস্যু টু রিলিজ দ্য মিল্ক, uterus for the uterine contraction during the term pregnancy. So in this way, this is different. This is different from the TSH, that is different from the GnRH, that is different from the others. Now a formula for you. Now a formula for you for your fiber. বলিস না এসব আমি শিখিয়েছি। FLATPEG ফিনিশ। নামগুলো বলতে বলতে থাক। নাম বল। F for L for L, A for ACTH, T for P for very good, E for আটকাবে কি? E for endorphins, coming later, endorphins, G for growth hormone, গ্লুকাগন নয়, এই যে গ্লুকাগন বললি তাই তো, বললি তো? Yes. So this flat peg, কে কথা বলছিস রে? ফ্ল্যাট পেগ, ফ্ল্যাটটা আলাদা লিখেছি আর পেগটাকে আলাদা লিখেছি কেন? These flats are not like that peg. Peg is like that. Directly they are coming to the tissue to action. Direct action করবে। Endorphins তাই। What is endorphins? Endorphins is secreted from many other sites of our body, including our pituitary. This is beyond scope of this class to discuss the endorphins. But remember, endorphins are a hormone that is released from different parts of our body, including the pituitary. That's why it is given as a formula. This is a flat peg. Flat peg এর মধ্যে ভুললে আর কোনোদিন ভুলবি না। কোশ্চেন খুব সিম্পল হবে। অ্যান্টি পিটুইটারি থেকে কি বেরোয়, পোস্ট পিটুইটারি থেকে কি বেরোয়? তো অ্যান্টি পিটুইটারি থেকে এগুলোই বেরোয়। কিভাবে কাজ করে জানতে গেলে নিউক্লিয়াস জানতে হবে। নিউক্লিয়াস কিভাবে আসে জানতে গেলে পোর্টাল সিস্টেম জানতে হবে। পোর্টাল সিস্টেম কোথায় এসে অ্যাকশন করে, দ্যাট মিন্স আমার সেলের নামগুলো জানতে হবে। সোমাটোট্রোপ, থাইরয়েডট্রোপ, ল্যাক্টোট্রোপ, কর্টিকোট্রোপ, সব নাম ধরে ধরে সব ট্রোপ, TROPE. And releasing hormone always tropin and inhibiting hormones. Both releasing and inhibiting hormones are coming from the hypothalamus. It's coming from the hypothalamus. So, এইটুকু কি কি বুঝলি বল, বেশি পড়িয়ে লাভ নেই। এইটা বুঝলে হরমোনের অনেক জিনিস তোর অ্যান্সার দিতে পারবে, অনেক অনেক কোশ্চেন অ্যান্সার দিতে পারবে। So first of all, endocrine system and nervous system is connected by hypothalamus. So there must be some neural part of the hypothalamus. What are the neural part? There is a nuclei, but nucleus. There are different types of nucleus are there. Lots of, around 20 nucleus are there. But I am explaining only about the 4, and 2 to 3 I explained about the ventrolateral, ventromedial, lateral, anterior, dorsomedial, dorsolateral, everything is there. একটা জিনিস মনে পড়লো তাই বলছি, ডর্সোমিডিয়াল যদি এখন কারো ডর্সোমিডিয়াল চলে যায় তাহলে সে এসে কি সব ভুলভাল পড়াচ্ছে বলে এখানে এসে আমাকে চর থাপড় মাত্রা করবে। দ্যাট মিনস দিস অ্যাটিটিউড, behavior, restriction, aggressive behavior, salvage is controlled by the dorsomedial nuclei of the hypothalamus. মনে পড়ে গেল তাই বললাম। So, preoptic, supraoptic, arcuate nucleus, paraventricular nucleus. আমি এখানে প্যারাভেন্ট্রিকুলার নিউক্লিয়াস বলেছি, কি কি বেরোয় প্যারাভেন্ট্রিকুলার নিউক্লিয়াস থেকে? corticotropin releasing hormone and the কি বেরোয় বল তোকে তোকে বলছি আর কি বেরোয় প্যারাভেন্ট্রিকুলার নিউক্লিয়াস থেকে কি বেরোয় বল বল you don't know. So this is the fate. This is the fate of your next generations. ক্লাসে আছে একটা প্যারাভেন্ট্রিকুলার থেকে কি আছে লেখা আছে তাও বলতে পারছি না। So your mind is not here, right? তাই তো মাইন্ড নেই তাহলে ক্লাস করে কি হবে অ্যাটেন্ডেন্স আমি তোকে দিয়ে দেবো কোনো অসুবিধা নেই আই উইল গিভ ইউ অ্যাটেন্ডেন্স ইফ ইউ কাম এনিবডি ফর স্যার আমার ভালো লাগছে না আমার ক্লাস চলে যাবো ইউ ক্যান গো এনিবডি একটা স্টুডেন্ট থাকলে ক্লাস হবে না তাও না থাকলে বেরিয়ে কিচ্ছু এসে যায় না আবার ডোন্ট কেয়ার দেখো সামনে সামনে বসে আছি প্যারাভেন্ট্রিকুলার নিউক্লিয়াস যত কথা বলছি বেরোচ্ছে না বল তুই বল প্যারাভেন্ট্রিক কি বেরোয় না দেখে বল বসে বল CRH TRH simple thing the TRH and CRH is coming from the paraventricular nuclei and then come to the কোথায় আছে portal hyper portal system hypothalamo hypophyseal portal system এ আসবে releasing hormone তো releasing hormone must become with the portal system into the anterior pituitary posterior pituitary কাজ কিন্তু আমি এখানে বলিনি কেন না posterior pituitary তে কি হয় আগে বলেছিলাম only store secretion in the hypothalamus but here this is secretion as well as store is happening you are seeing that so there is a rule that the rule of the hormone so these will coming down and then activates the adenopart that some cells are there that is for the CRH corticotrope TRH for thyroid trope simple and then it goes to the target cell thyroid gland and as well adrenal cortex from the adrenal cortex it releases the cortisol mineralocorticoid etc whatever it needed it is releasing and then this is the T3 T4 is coming if any one hormone suppose cortisol খুব বেশি বেরোচ্ছে then negative feedback will come negative feedback come to the কোথায় আসবে pituitary gland কাকে cortisol খুব হাই বেরোচ্ছে suppose cortisol is high will suppress কাকে সাপ্রেস করবে কর্টিকোট্রোপকে সাপ্রেস করে দেবে আগে একে ভাই তুই থাম তুই আর এসিটিজ বের করিস না এসিটিজ এত বের করেছিস যে অ্যাড্রিনাল কর্টেক্স স্টিমুলেট হয়ে কর্টিসল লেভেল বেড়ে গেছে সো সাপ্রেস করো and again cortisol again it suppress paraventricular nucleus to restrict the release of corticotropin releasing hormone also this is called negative feedback mechanism in this way everything is going on so now one important nucleus is I escape that is the কি আছে supraoptic থেকে কি বের হয় ADH আরেকটা ছিল অক্সিটোসিন সেটা করতে বের হয় প্যারাভেন্ট্রিকুলার নিউক্লিয়াই ভেরি গুড তাহলে প্যারাভেন্ট্রিকুলার নিউক্লিয়াই আমি ইচ্ছা করে বলিনি তখন প্যারাভেন্ট্রিকুলার নিউক্লিয়াই থেকে অক্সিটোসিন and supraoptic থেকে আমার বের হচ্ছে ADH both are নিউরোসেক্রেটরি সেল থেকে বেরিয়ে এসে এই পাথওয়েটা নেবে and that will store here not secretion here now when it is released when we are dealing with some hyper osmolarity of the blood আমরা অনেক ছুটেছি ভাই গরমে তোরা এই ক্যাম্পাস থেকে ওই ক্যাম্পাস যাচ্ছিস you are sweating profusely so your blood volumes and some water loss is there some sorts of dehydration is there so you are dealing with a high solute with less solvent কি হবে hyper osmolarity হবে তাই তো হবে তো নাকি hyper osmolarity মানে ঘন মানে বেশি সল্ট with less volume is less তাহলে hyper osmolarity হবে then hyper osmolarity of the plasma it acts as a secondary triggering factor of the supraoptic nuclei তাহলে এই যে সুপ্রাঅপটিক নিউক্লিয়াই সুপ্রাঅপটিক অপটিক প্লাজমার উপরে সেইটা যেহেতু আমার হাইপার অসমোলার ব্লাড or hyper osmolarity that acts as a triggering factors to release ADH this ADH is come through the neural connections into the posterior pituitary that may be stored that may be released ADH will be secreted and goes into the blood এখান থেকে ADH বেরিয়ে গেল ADH is to blood and then it will go কোথায় যাবে DCT and collecting tubules. Remember কি করবে এখানে ওয়াটার রিঅ্যাবসর্পশন করবে কিভাবে করবে aquaporins incorporation aquaporin 1 and 2 that is the water channels এটা দিয়ে these will come reabsorption of water কেন রিঅ্যাবসর্পশন দরকার ছিল আমার আমি ঘেমে গেছিলাম আমার ওয়াটার লস হয়েছে আমার ওয়াটার চাই কে করবে কিডনিকে বলো ভাই তুমি করে দাও কিডনিকে বলো ভাই ভাই তুমি এটা দাও কিভাবে দেবো আমার জন্য অ্যাকোয়াপরিন দরকার হ্যাঁ অ্যাকোয়াপরিন আমি দেবো কিভাবে দেবে তুমি আমার জন্য ADH আছে ADH whenever is connected to the ADH2 receptor also present in ADH1 also different sites ADH2 receptor is there when ADH connected to the distal tubule and collector tubule there's incorporate is a huge mechanism I will come in details if our department allow to speak about the kidneys hormones and then I will speak so ADH will come and this aquaporin incorporations into the renal tubules and then reabsorption is going on in the collecting and distal tubules reabsorption of water means we are replenishing the water আমার এটা বাড়ছে তাহলে কি হবে হাইপার অসমোলারিটি বাড়বে না কমবে মানে অসমোলারিটি কমে না বাড়বে কমে যাবে রাইট যেই কমে গেল স্টিমুলাসটা বন্ধ হয়ে যাবে in this way thrust mechanism also come thrust center is there in the hypothalamus also they also sense the thrust by the through of osmoreceptor osmoreceptor also present in the supraoptic nuclei so there is a relation there is a relation এর কোনো শেষ নেই আর মেডিকেল সায়েন্সটা এরকমই একটু ফাস্ট ভালো লাগলে কন্টিনিউ করবি নলে ছেড়ে দিয়ে বেরিয়ে যা প্রচুর লাইন আছে নলে ইউ উইল বি বিগ ট্রাভেল ইন ফিউচার পেশেন্ট দেখে খেতে হবে ভাই নলে কিন্তু মুশকিল কেউ শেখাবে না তোদের পরে তো কেউ শেখাবে না টাইম কোথায় একটা তো স্টুডেন্ট বেরোচ্ছে আগে একটা 10 বছর আগে 15 বছর আগে যেমন ইঞ্জিনিয়ারিং বেরোতো নাও ইট ইজ কামিং অ্যাজ আ মেডিকেল স্টুডেন্টস কতগুলো মেডিকেল কলেজ বলতো they are coming jobless only one option is that your knowledge you only can stand with your knowledge with your own knowledge তাহলে কেউ আটকাতে পারবে না otherwise if anyone be a বাইরে থেকে পড়ে আয় তুই এমডি করে আয় কোটি কোটি টাকা খরচা করে আমি তোর পাড়াতে গিয়ে বসলে আমার পেশেন্ট হবে 100% sure if you have lack of knowledge and lack of your diagnosis wrong diagnosis it will come আজকে তোরা ফার্স্ট ইয়ার কেউ হাসছিস পাচ্ছিস না বুঝতে তাই তো পরে বুঝতে পারবি যে এই কথাগুলো কেন আমি বলছি some basic things are important I am not telling you to learn একদম এক্সটেন্সিভ এই সবগুলো বলছে this basic thing important is that এখানে কি কি তাহলে হলো বেসিক hypothalamus থেকে releasing hormone inhibiting hormone is coming and then portal system then a gland is coming to stimulate then hormone is coming to come to the target organ to release further hormones that is the basic thing আমি যদি নিউক্লিয়ার নাম ভুলে যাই কিচ্ছু এসে যায় না অন্তত এটা তো বলতে পারবো যে সাম নিউক্লিয়াই থেকে আমার সিআরএইচ টিআরএইচ বেরোয় that is also enough for also MBBS pass out patient anything আমি নাম বলতে নাম নিয়ে আমার কি লাভ আমার নাম জেনে কি লাভ সত্যি আমার কোনো লাভ নেই but it is in your theory that is you have to learn that's why but if you tell that is the nuclei is there to release the releasing hormone and inhibiting hormones are there that's enough for you now these are the four mainly hormones the supraoptic already done paraventricular nucleus this is oxytocin are there paraventricular nucleus come to the nuclear neurosecretory cells and then stored and they release কখন বেরোবে oxytocin during the breastfeeding it is released during the breastfeeding is oxytocin reflex will come the breastfeeding is a triggering factors for what for the paraventricular nuclei as well as during the parturitions that is also important for the contractions so these are the important for the your oxytocin and ADH so actions are the cells are the and the nuclei center is the different is the supraoptic releases the ADH paraventricular nuclei is this now the question is that sir ওখান থেকেই অক্সিটোসিন বের হচ্ছে আবার ওখান থেকেই আবার সিআরএইচ টিআইএইচ বের হচ্ছে কেন yes these are good questions for the good students extraordinary good students make asking questions and I am ready for that answer because in the paraventricular nuclei two types of cells are there one is magnocellular another is a parvicellular one is the magnocellular So is the paraventricular nucleus. Two types of cells are there. That is a magnocellular, and then another is a parvicellular, parvicellular. Okay, so this magnocellular part releases the TRH and the CRH, but in the parvicellular part, it is releases the key oxytocin. Finish. So everything is detected in our brain. Everything is discussed in everything, everywhere. কোনোটার unexplained নেই. Explanation হবে না, তা হবে না. This is science. This is called medical science. Each and everything is important, but these cells are theoretically important. No practical importance is there. Practical importance is there. That is the ADH, how it is act. It is a different entity, and also the oxytocin. So, বোঝা গেল? কে 50% ইয়ে করলি, 50% কে বুঝলি বল? 1 2 3 4 5 6 7 8 9 10. Leave it. So these are the basics of our further classes, because further class I will take, suppose growth hormone, suppose I can take thyroid hormone, anything I can take. And that is a first. That is a used thing. How it is growth hormone can act, how it is increasing the mass, bone. But remember the flat pegs, flats for the FSH, LH, ACTH, and the TSH. Peg for the prolactin, endorphins, and the growth hormones. Finish of these anterior pituitary hormone. If pituitary hormone to জিজ্ঞেস করে তোদের পরীক্ষায়. Now question is something asked like the, what do you mean by prolactin inhibiting hormone? Prolactin inhibiting hormone means it's a dopamine. Normally this is an inhibiting form to suppress the lactotropes, but if its concentration is less, especially during the childbirth, during the use of estrogen, during the use of oral contraceptive pills, the level of PIH concentration is less, so that lactotropes is activated. Yes, if concentration of PIH is less, then inhibitory effect will go on, and then the positive influence will come to activate the lactotropes, and then lactotropes will release the prolactin, and prolactin will function further. Simple. Okay, so this prolactinoma is a clinical part, is a tumor having the prolactinoma, means prolactin বেরোচ্ছে, pituitary থেকে is coming profuse amount of prolactin. That is also dangerous. Prolactinoma. Pituitary adenoma is a pituitary tumor. Pituitary apoplexy, it will come in your book also probably. So these are the apoplexy, means pituitary destruction is there. Pituitary destruction is there. If there is destruction, there is lots of lack of hormones of the anterior pituitary hormones, that is flat pegs. Tractiosus come less. If it is less, then some diseases like the Addison's disease. What is Addison's disease? It is a destruction of the mainly the pituitary corticotrope cells. Corticotrope cell destruction. By how? Immune mediated problem. Immune system derivatives of destructions of the cells. Which cells? Corticotrope cells. If corticotrope cells is destroyed, then how acetate will release? If it is not released, then that not activate into the adrenal cortex to release the cortisol. So cortisol level is less. So cortisol level is less, acetate is less, presentation will come as the patient is a fatigue, lethargic, darkening of skin. Presentation is like a Addison's disease. Most common symptom of Addison's disease is weakness. Any patient come without any reason, you are getting regularity that coming, that is the weakness. So definitely you have to suspect about the Addison's disease by finding the other clinical features like the hyperpigmentations is another important part. Because in the corticotropes, another important hormones releases. Bol. MSH. Melanotropic basically. Melanotropic or melanocyte stimulating hormone. Basically it is melanocyte stimulating hormone. melanocyte stimulating hormone in the acetate is gum, but its form is another alpha, beta, gamma is present. I'm not going to details into this. Different types of these are coming, and that's why this melanocyte will increase to compensate the decreased acetate. With the melanocyte stimulating deposition, melanocyte deposition is there. So darkening of skin, dark pigmentation of the skin is a characteristic finding of Addison disease. I have seen 2 to 3 cases of Addison disease having the hyperpigmentation of the knuckle is present. Nothing else. Weakness is there, but there is no so much important. Important of that patients, that is the hyperpigmentation is there. This is a typical feature of Addison's disease. That means some immune-mediated destruction of corticotropic cells due to the tuberculosis in the past area. Nowadays, it is common with very HIV infections. Immune-mediated destruction of the corticotropes may present as Addison's disease. Just like go through your book, this Cushing syndrome, Cushing disease, Addison's disease, okay, pituitary adenoma, pituitary hyperplasia, pituitary apoplexy, these things are in your book, probably. I never ever go through your books. I don't know what is present in your book. But this is have to learn. This class is for the learning, and so most easiest way you have to learn this. So in this way, we can present of any hormone of endocrine system that is released from the pituitary glands. Please silent. So in this way, you have to know about the growth hormone. You have to know কথা বলিস না আমি ক্লাস শেষ করিনি কিন্তু এখনো why are you starting? So this growth hormone have to learn পড়ে আসবে growth hormones FSH LH SCTH thyroid hormones questions may come any day any time any semester will come, and if this gross idea you have 10 to 11 students, I am sure you will get at least 50% marks, and that is enough for you. That is enough for you. But to get 50% mark, you have to reach at least 70% preparation. Then only you can get 50%. If you target 50%, then you get 20%. আমার পেয়েছিস এবার 3, 4, 6 বছর আমার পেয়েছিস আমার কাছে একটা খাতায় ছিল বোধ হয় 30 পেজ ইজ গুড এনাফ জানি না স্যার টুকে লিখেছে না কিভাবে লিখেছে জানি না সো if it is that, so it's good. So dismiss my class. Thank you very much. Any queries up to this? Anyone? No. Thank you.
Basically, glucose is the main source of energy. You already know. It is the main source of energy. We use glucose as a primary source of energy. And many of the organs directly utilize the glucose as a main source of energy. And if the glucose level is disoriented from the normal range, it causes several diseases. Like one important disease, diabetes. Okay? And for a regulation of blood sugar, there are several factors that comes, like the hormone, insulin, glucagon, pancreatic activities, and thyroid activities, growth hormone. Many other things are important to maintain the regulation of blood glucose. Because you already know it, because metabolism topic is already covered in detail. So write in few lines about this. First of all, you make the heading A, quantitative estimation of blood sugar. इसमें लिखो the term blood sugar. The term blood sugar indicates the all hexose present in the blood. Hexose sugar. Okay. Glucose is the main hexose sugar in the blood. Glucose is the main hexose sugar in the blood, and it is essential for brain and RBC cells of the body. And it is essential for brain and RBC cells in the body. RBC cells in the body. RBC cells essential nutrient for brain and RBC cells in the body. Okay? इसमें लिखिएगा level of blood glucose, not alert. Blood glucose is an important indicator of body function. Huh? Level of blood glucose is an important indicator. Is an important indicator of normal body function. Normal body function. And to maintain in normal range. In normal range. Okay. So students, there are several methods to maintain it in normal range. Normal range. Okay. So there are several methods for estimation. Okay. Why I am telling you all these methods? Because during the viva of your practical, these questions may ask to all of you, which is the other method rather than this method. So we can divide the first one enzymatic method. Enzymatic methods. These two methods are there. Okay, note down. Enzymatic method in which the first method is hexokinase method. I will ask the question after the class. So read carefully. Hexokinase method. Second method is GOD, POD. GOD stands for very good. Glucose oxidase peroxidase method. There you go. Madam, why are you late? Huh? Glucose oxidase peroxidase method. Okay? So this is both are what? GOD, POD. This is enzymatic method. Okay? Now second one is non-enzymatic method. Non-enzymatic method. At least you have to know the name of this non-enzymatic method, because this question may ask in your viva which one is enzymatic method, which one is non-enzymatic methods. Okay? So non-enzymatic method is first one ortho-toluidine method. Ortho-toluidine method. Second one is Pauling-Gu. Pauling-Gu actually the type of apparatus from which we can see the normal level. It is oldest method. It is oldest methods. Okay? Pauling-Gu methods. Third one is King's and Astor method. Astor method. King's and Astor methods. Why the name of this method, King's and Astor? Yes, because these can make some paper. You can write it the values. Not allowed here, not allowed in the class. Okay. The last one is Nelson-Somogai. Last method is Nelson-Somogai. Don't talk. Nelson-Somogai method. Student, be serious. Please come on the time. टाइम का वैल्यू करना समझ लो. Nelson-Somogai method, ortho-toluidine, Pauling-Gu, King's and Astor. Nelson-Somogai. Nelson-Somogai method. Yeah. Hey, Nanda. Yes. It is non-enzymatic method. In which non-enzymatic method is ortho-toluidine, Pauling-Gu, King's and Astor methods, Nelson-Somogai method. Okay, these are the other method rather than enzymatic method. Okay. Now, student, understand. We perform here in the lab, in your practical lab, you perform only a one method, that is theory method. Okay? So make heading glucose oxidase peroxidase method. 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 Yes. Then, before performing the sample, before performing this test, GOD test, GOD test, we require sample first. We require blood sample. We require blood sample in which first sample is fasting, second sample is random. Sorry, random. It is post-perineal. And third sample is random. Random blood sugar, we call it random. So now any one of you can give the answer what is the meaning of fasting, post-perineal and random blood collection method. The basic, just a minute, listen question. The basic difference between all of these. Yes, one by one. Then listen carefully. আমি বাংলা বুঝি না বাংলা কম तो सुन लो बांग्ला में मेरे बांग्ला नहीं आती थोड़ा बहुत आती ही आती है ये सेट है बांग्ला बुझी नहीं आपको क्या अलग डिफरेंस बताइए
fasting is morning in the evening storm.
No, yes. Give the answer. I already tell you. Give the answer. Who satisfy all the requirements? Yes, you.
Sir, after 8 to 12 hours of fasting, after night, after taking dinner, next morning 8 to 12 hours of gap.
Anybody else want to? Last one. Same answer. Okay. Now listen the answer. Actually, for the blood sample collection, if we make a preparation, if we make the preparation to draw the sample, what type of preparation? We have at least fasting for 8 to 12 hours. We have fasting, we have take meal before 8 to 10 hours. So it is called fasting. Okay. So what is the important for fasting blood sample? That is preparation. What type of preparation? Preparation is that you have to take the meal before 8 to 12 hours. It is for fasting, and for PP, it is you collect the blood sample within 2 hours, or at least you have to complete the 2 hours after meal. Okay? It is called post-perineal. And both the samples are collected on same day. What is happening in the OPD nowadays? Patients are come, they give fasting on one day and post-perineal on the next day. It is right or wrong? It is totally wrong. Okay, fasting blood sample will collect on the same day after the post-perineal on this day. Okay, so this is very important to collect the sample on the same day, and there is need of preparation for fasting blood sample and post-perineal blood sample. If we collect the sample without any preparation. In at least we collect the sample at 24 hours of sample within a day. It is called random. Understand? Okay. So there is the collection of blood sample is fasting, postprandial, and random. Yes. Huh? Random. Random. There is no need of preparation. You have to collect the sample within 24 hours anytime. Okay. There is no need of preparation like fasting, like postprandial. There is no correlation with the time with the meal you will take. Understand? So you make the addict fasting sample. I will also dictate it. You will write it. Fasting sample collected after overnight or 12 hours of fasting. Sample collected after overnight or 12 hours of meal. Meal after 12 hours of meal. After 12 hours of meal. Postprandial after fasting sample. Postprandial लिखिएगा after fasting sample. A patient taking carbohydrate meal. A patient taking carbohydrate meal. It contains 75 gram of. It contains 75 gram of sugar in adults. And 100 gram sugar for pregnant women. And 100 gram sugar for pregnant women. And for pregnant women. First stop. Sample collected after 2 hours. Sample collected after 2 hours. Sample collected after 2 hours. Marathon. क्या हुआ? 100 gram sugar for pregnant lady and sample collected after 2 hours. Random. Sample will be collected at any time after a meal. Sample will be collected at any time after a meal. Sample will be collected at any time after a meal. Okay. Now write down the principle of this test. Write down principle. देखिए glucose oxidase act on glucose. Glucose oxidase act on glucose to produce gluconic acid. To produce gluconic acid and hydrogen peroxide. And hydrogen peroxide. Breakdown of hydrogen peroxide by peroxidase is further react with oxidation of phenol. Further react with oxidation of phenol. Okay, full stop. The phenol complexes with 4 amino antipyrine. The phenol complexes with 4 amino antipyrine. Amino antipyrine ANTY-PYRENENT pyrene to give red color quinone complex. To give red color quinone complex. To give red color quinone complex. Quinone complex, red color quinone complex. This is QUINONE. Quinone. Okay? Glucose react with in the presence of H2O. Enzyme material is glucose oxidase. 14 dot of gluconate plus hydrogen peroxide. When this hydrogen peroxide react with 4-amino antipyrine, 4-amino antipyrine in the presence of peroxidase, it gives red quinoamine dye complex, red quinoamine dye complex plus H2O. Red quinoamine dye complex plus H2O. As per your principle, when the glucose oxidase react on glucose, okay, it forms gluconate and hydrogen peroxide. And this hydrogen peroxide is react in the presence of peroxidase with 4-amino antipyrine. It forms red quinoamine complex and removal of one hydrogen. Okay. So as per you already know, for the quantitative estimation, what we require? We require color complex. What we require? We require color complex. With the intensity of this color complex, we confirm the concentration of the glucose in the sample. By which law? Very good. Lambert's and Beer's. Okay. Okay, write down. Reagent required. Glucose oxidase, peroxidase reagent. Glucose standard solution. Glucose standard solution, that is 100 mg per dl, ब्रैकेट में लिखेगा 100 mg per dl, 100 milligram per deciliter, 100 mg per dl. Okay. And the third one is 4-amino antipyrine. 4-amino antipyrine. 4-amino antipyrine. 4-amino antipyrine. But actually, students, we have already prepared reagent kit which we use in the diagnostics. We already have. So in this kit, there is in the reagent 4-amino antipyrine is already present. Okay. So here we don't add 4-amino antipyrine directly. Okay. It is now we make the adding procedure. The procedure same as the creating method. Write it. Take 3 test tube and mark them as a test, blank and standard. Take 3 test tube and mark them as a test, blank and standard. test, blank and standard. What is the meaning of standard? Yes. At least you know the concentration of the substance complex in the solution. Reagent, test, blank and standard. For blank what we use? Distilled water. Okay. So now write it first. Sample either blood serum or CSF fluid or pleural fluid. CSF or cerebrospinal fluid. Okay. Sample, we take it sample. Here we add 20 microliter distilled water, 20 microliter. Hey, don't talk. Good talk. Okay. And standard 20 micro liter. Now reagent. Reagent is what? What reagent? Yes. POD. That is 2 ml. 2 ml and 2 ml. Okay. How much volume you kept in a single test tube? How much volume you kept in a single test tube? 220 microliter.
2020
Yes, 2020 microliter. इसमें आगे इसके बाद देखिएगा mix it and leave for 2 minutes at room temperature. Mix it and leave for 10 minutes in RT in room temperature. Leave for 10 minutes in room temperature and take optical density at 520 nanometer. Take optical density at 520 nanometer. 520 nanometer. Understand? Take optical density at 520 nanometer. Okay? So now the next heading is observation. You already know because it is same. All the quantitative practicals are same as the creatinine or the blood sugar. Okay? Observation, OD of test, OD of blank and OD of standard. Write it. OD of test, OD of blank and OD of standard. Student, whatever I dictate you all write in your fair copy. सारा कुछ fair copy में लिखना है. When I will check the copy, I had seen that many of the students don't write it the creatinine clearance. Why? All of you write the creatinine clearance also. जो हम आपको बता रहे हैं ये सारा आपका important है. Not the exam point of view, it is already it's comes when you sit in the OPD to see the patient. Understand? So write it in your copy. So now write down calculation. OD of shed upon OD of standard. OD is optical density. It is same as absorbance. Both the terms are same. Okay? OD of test upon OD of standard minus OD of blank minus OD of blank multiply by C upon V into 100. C upon V is what? Right? You इसमें formula लिखेगा where is C is a concentration of standard solution, V is a volume of sample.
Yes.
Volume of sample. It is not test. Volume of sample is what here? It is blood. But Student, we don't use directly blood here. We use protein-free filtrate solution. Protein-free filtrate means we separate out all the proteins from the blood and the content with the supernatant which we got, we use for the detection of this blood glucose. It is not serum because we exclude all the protein part. We exclude all the protein part by different methodology. All the protein factor we remove it. Okay, so that we say it is serum is correct. C upon V into 100. Okay.
What is C?
Concentration of blood, concentration of standard solution. Okay. And V is the volume of sample. So for this factor, we directly put here 1. It is 1. And the formula which we directly come here is OD of test upon OD of standard minus OD of blank upon OD of blank minus multiply by 100. Multiply by 100. This is the final calculated formula blood for blood glucose. Okay? Final calculated formula blood for blood glucose. So the result is come is in the unit of mg per dl. Which factors value comes in gram per dl? Anybody of them? Which parameters, which value of the blood is comes in gram per dl? Hemoglobin is correct, but some other. It is total protein. Total protein, we calculate the total protein in liver function test. It is the factor which is comes in gram per dl. Okay. So result you will write it here. Result and make the language. Listen carefully. When you perform this test, it is important to take the proper protocol to perform it. Okay? But it is also important in the exam that you have to write in a proper way in your copy. Okay? If somebody is checking your copy and you don't write in a proper format, why I will dictate you? Why I will dictate line by line to you? You have to write it because you follow this protocol, you follow this writing method in your exam copy. Okay? So lastly you will write the result. It is comes in everybody here and make the result. This is the result and इसमें लिखिएगा the blood glucose is इतना in given sample. Okay. Now write it. Clinical interpretation. Clinical interpretation means clinical interpretation. Okay. Clinical interpretation means normal range. Normal range. Okay. We take the sample in three formats. That is, first one is fasting, what we call MBBS, fasting blood sample, and the range is 70 to 110 mg per dl. Okay. Postprandial it is we call MBBS or we call after a meal. It is 100 to 140 mg per dl. Okay. And last one is random. Random blood sugar. This is not more than 140 mg per dl. Not more than 140 mg per dl. Not more than 140 mg per dl. Okay. This is the normal value. If the value comes more than this value, more than this value, more than this value, then this condition referred as hyperglycemia. And if the value is less than 60 mg per dl, it is hyperglycemia. Understand? So now, from this condition, I will ask all of you, because you already complete carbohydrate metabolism. What is the WHO, World Health Organization criteria for diabetic subject?
So less than 126 in case of
Which one?
fasting.
Fasting. It is less than
126.
okay, 126 mg per dl. And for random and MBBS,
Less than
more than
1.
200. Not more than 200.
it is less than 20 mg per dl. Okay, so the value which is comes between these, what they call?
Impaired
No, this is called, we generally call it in our terminology, it is pre-diabetic. What we call? Pre-diabetic. So students, in this condition, in the pre-diabetic condition, there is no requirement of treatment. We manage such kind of patient with the nutrition and customized diet plan. In the customized diet plan, what we give to the patient, we don't allow the patient to take more carbohydrate diet. So to remove all the starch, all the polysaccharides, potato, rice, and all the carbohydrate need to be in minimum quantity. Okay, so this condition referred as pre-diabetic. Okay, this is the clinical interpretation. Now write down hyperglycemia. Make heading hyperglycemia. Increase of blood sugar from above normal range. Hyperglycemia we generally call at the level of 180 mg per dl. Okay, 180, 170. So write it causes of hyperglycemia. You will tell the causes of hyperglycemia. All of you tell the causes of hypoglycemia.
Stress, obesity,
Huh?
obesity,
Obesity.
stress,
Want to turn on the sugar? You directly confirm that if there is hyperglycemia, there will be chances of diabetes. By second one is hyperthyroidism. Hyperthyroidism. Any disorder related to pancreas? Pancreatitis. What the meaning of pancreatitis? Now you will tell. Inflammation is what? What the meaning of inflammation?
yes. That was more tolerant also obviously.
Very good. Now explain it. Explaining good.
In the inflammatory part, temperature will be raised, then redness, then swelling and loss of blood supply that leads to cause of ischemic or
Right. Pancreatitis means inflammation is basically four types. He clearly mentioned dollar, Baylor, or some other terminology we use. So pancreatitis, fourth condition is increase adrenocortical activity. Increase adrenocortical activity. When I will teach you the diabetes mellitus in HCD class, I already tell you that with the growth hormone, with the regulatory hormone, with the steroid hormone activity, there will be chances of increased blood sugar. Okay, so these all are the causes of hyperglycemia. These all are the causes of hyperglycemia. Okay, and the cause behind the diabetes mellitus is different. Like type 1, type 2, it is other things. Okay, but generally, the examiner asks you what is the defect of hyperglycemia, why hyperglycemia occurs in the body. So you will tell just 4 reasons. Okay. Now write it. Hypoglycemia. Hypoglycemia. Decrease in blood sugar below normal range. Okay. Now what are the cause of hypoglycemia? How have to tell one by one?
High renal threshold.
Huh?
High renal threshold.
High
Renal threshold.
renal threshold. So it is producing.
So ज़्यादा renal threshold होगा तो अगर कम भी है तो भी निकल जाएगा। renal threshold कम होगा तो black रहेगा।
Renal threshold होता कब?
होता है 180 नॉर्मल है।
The condition referred as glycosuria. Understand glucosuria? What is the meaning of glucosuria? Presence of glucose in the urine. But the reason is that why glucosuria occur?
Cellular intake of
No. Anybody else? When a person is suffering from hyperglycemia, it is 180 mg per day. Okay. So there is renal tubular reabsorption is less. Okay. renal tubular reabsorption is there. So what happens? There is spilling of this blood glucose in the urine. Increase spilling of this blood glucose in the urine. And person suffers from glucosuria. Okay. So their renal threshold value is high, but the reason is hyperglycemia. Understand? So this is not the cause of hypoglycemia. Generally, glucosuria, renal glycosuria generally causes at the condition of hypoglycemia. But what I asked what is the reason of hypoglycemia? So it is by first reason is administration of insulin. If such patient taking insulin in the high form, that directly goes to our condition, we call it insulin shock. Okay, so it is mandatory to take the insulin in a normal range. Second one, if pancreas doing hyperactivity, what happens? Hypothyroidism, that is hypothyroidism, at point hypothyroid administration of insulin, patient going to a severe condition, insulin shock, if it is not treatable, there will be chances of coma. Patient going to coma. Why? Why? There is a secondary source available for the brain, which is what is the secondary source of energy for the brain? Ketone bodies. Okay, but when there is ketone bodies is more in the blood, what happens? Huh? Ketoacidosis is the other thing. It is occur. Ketoacidosis is occur. But when there is, it is type of intoxication. Okay. When brain take higher amount of ketone bodies, the brain cell become disoriented. Okay. So there will be chances of coma. We call a term encephalopathy. What is term? Encephalopathy. This is the condition generally occur. Encephalopathy. Okay. Hypothyroidism. Okay. Write it. Hyperadrenalism. No, hyperadrenalism. It is hypoadrenalism. Hypoadrenalism. Okay. Third point, fourth point. Severe alcoholism. Severe alcoholism called hypoglycemia. If some people taking regularly intake of alcohol, they feel dizziness, they feel lethargy. Okay, why? Because the rate of the glucose formation is slowed down by the intake of alcohol. And in the condition of starvation, fifth one, and last one is very last, Addison's disease. Addison's disease. Addison disease. Addison disease is generally related with the Okay. So addition disease, these all are the causes of hypoglycemia. That means generally it is less than 70 mg per year. So now tell me which condition is more severe, hypoglycemia or hypoglycemia? Hypoglycemia. Because if the person is feel hypoglycemic, they directly admit to the emergency ward. Once the time you lower the blood glucose by the administration of such drug, like if the blood sugar level is more than 580 mg per dl, it is 480 mg per dl, you directly put the injection of insulin to the patient, and after the 15 or 30 minutes, the blood sugar level is in control. Okay, blood sugar may be low. But during the hypoglycemia, by providing the glucose, it is not important that patient become taking the blood sugar level become high. It still at least sometimes. Okay, that's why the condition of hypoglycemia is more severe. Okay, so these all are about the clinical interpretation. These all about the diabetic condition. These all about the related with your blood glucose estimation. Understand? Now summarize the practical that we perform this test of blood glucose by GOD-POD method. It is an enzymatic method. Okay, which one is non-enzymatic method? We have to listen carefully. We have 6 types of methods. The first method is enzymatic method, in which exokinase method is first. GOD-POD method is second. Non-enzymatic method is orthotolerant, foreign to things and has to nasal from. Okay, so these are non-enzymatic methods. Principle, you know, in the next class, we perform this test in the lab and make the report of your sample. We are going to discuss about the estimations of serum blood glucose. In the previous practical, we all performed the quantitative estimation of serum creatinine. By which method? Jeffries method. Very good. Now, today we are going to perform a test, quantitative estimation of blood glucose by different method. So first of all, you understand what is glucose. Anybody else? Stand up. Give the answer. What is glucose?
It is 6 carbohydrates.
By which method you can identify?
Pyrethrin test.
Close the door. Close the door. By which method you can identify?
Pyrethrin test.
Huh?
Pyrethrin test.
Pending test. Very good. Why it is important to investigate the blood glucose?
Okay, so briefly for the stomach, what are the part of stomach you know? It has got fundus, then body, cardiac part and the pylorus. So in the cardiac part, between the lower end of esophagus and up to the first part of the stomach, what is it is called? There are 2 types of angle, right? What are they? প্রথম যে অ্যাঙ্গেলটা বললো সেটা কি নাম? Angle of His. Okay, angle of His. Then another angle is that is from the body and the pylorus, that is known as incisura angularis. Incisura angularis. Stomach is already over now. So how many curvature it has got? The greater curvature and the lesser curvature. So in the greater curvature, if you see very nicely, there is one thing that is known as stomach weight, right? So what is stomach weight? Huh? Bolo, which is known as stomach weight? Lesser sac. So you are saying lesser sac. Lesser sac is a part of. It is the part of the peritoneum. Okay. So it is the part of the peritoneum which covers the posterior part of foregut. Okay, which covers the posterior part of foregut. As you know, stomach is a part of foregut. Okay, because up to the second part of duodenum. So lesser sac is present where? On the posterior surface of stomach. Okay, so which structure comes in contact with stomach bed? Who will say? কতগুলো স্ট্রাকচার আছে? First one is spleen. First structure will be come in contact with spleen. Then second one is just think about the posterior surface of stomach. It is present on the left side. So which are the things? So for going further, if you know the tongue, right? Oral cavity. So it is extend from where to where? Tell me what are the part of tongue? Ball. Overall, it has got two surface. One is known as dorsal surface, another one is ventral surface. ठीक है? Then it is known as one is attached to the floor and another one is known as the root. Right? So which one is the root? The extension part. Okay, extended part. যেটা আছে সেটাকে বলে root. Then where it is attached, কোন জায়গাতে attached থাকে? On the floor of the oral cavity. Okay. তাহলে কোনটা ডরসাল সারফেস? যেটা দেখা যায়। ভেন্ট্রাল সারফেসে তাহলে কি থাকে? Ventral surface. Which things are present on the ventral surface? কি কি? Lingual frenulum. Very good. And
opening of submandibular.
which one is lingual frenulum? Please say. If you see the ventral surface of tongue, right? There you get one vertical line. Okay, which is going on the midline. So that is known as frenulum lingual. Okay, and there is two lingual veins on the both sides. So tell me one thing. There are three salivary glands, right? One is the parotid gland, another one is the submandibular, another one is the sublingual. Where does it open?
Parotid opposite to crown upper second.
Opposite to the crown of upper second molar tooth. What about mandibular and sublingual? Submandibular and sublingual.
Sublingual तो नाम ही है.
কোথায় দাদা কোথায় হবে? So just remember frenulum lingui just beside. Okay, just beside there is the opening of the sublingual gland. Okay, and the duct of sublingual gland and submandibular gland opens into on the floor of oral cavity. Okay, remember these three things. Okay, used to comes in MCQ. Okay, so this term is a what is the definition? It's a muscular organ made of skeletal muscle. Actually, it is a skeletal muscle. Why it is voluntary? Right? We could control the movement of tongue. Okay, so that's why it is a skeletal type and voluntary muscle. Okay, and it is covered by both intrinsic and extrinsic mucous membrane. Actually, there is one mucous membrane. Okay, so what is the importance of mucous membrane? Oral mucosa না থাকলে কি হবে? যে স্যালাইভা থাকে সেটার মধ্যে কি থাকে? It is acidic or basic? Acidic. Okay, কারণ ট্যানিন থাকে, right? Lysozyme থাকে, and there are different type of food particles. So it could harm the mucosa, oral mucosa present on tongue. Okay, so that's why this mucosa always remember it is covered with mucous membrane. Okay, so this is what is the lining, that is very important. Write it down. Okay, lining of the mucous membrane is stratified squamous cell. Okay, so what is stratified squamous মানে কি? প্রথমে কি থাকবে? বেসমেন্ট মেমব্রেন, দেন লামিনা প্রোপিয়া, তারপরে কি থাকবে? নেক্সট লেয়ারটা হবে কলাম। Okay, then there will be cupoid. Okay, so this is on the stratified means ki what these squamous cells are arranged in different layers. Okay, but remember the above would be the flat cells, then would be the cuboidal, then would be the column. So what is the lining epithelium? Stratified squamous epithelium. Okay, then suppose if you are saying about the nasopharynx, what would be the lining? Nasopharynx already over na, lungs and trachea are full. What is the covering? Epithelium টা কি? Respiratory epithelium টা বল রেসপিরেটরি এপিথেলিয়ামে কি আছে? Who will tell what is the lining epithelium of respiratory tract? Already over.
Non-keratinized.
Pseudostratified ciliary epithelium. Okay. Pseudostratified non-keratinized ciliary epithelium. Okay. So what in the teeth there is presence of filiform papilla and there is underlying on the lateral part also. Okay. So see, this is the extension of tongue. So you could see how does it extend? Which one is the tongue? This is the tongue, right? So this is the root of tongue and this is the floor of the tongue where it is attached. What is this bone? It is the mandible. Okay, so the tongue is attached over here. Then it extends like that and there are numerous muscles present on the tongue. Okay, we will study in the head neck brain. Okay, there are numerous muscles like genioglossus, styloglossus. Okay, these are the muscles of the tongue. Okay, so in general, what are the things you could see in the tongue? See, you know, in the tongue there are numerous type of papilla. Okay, so in histology slide you have to determine which are the type of papilla present on the tongue. Okay, tell me which are they? Siruti bol. Kiki papilla thake. So you are somewhere else. Bring you back to the class. Bol.
Circumlicular papilla.
Circumferent papilla আর কি থাকে? Filiform papilla, fungiform papilla, আরেকটা কি থাকে? Foliate papilla. Okay, these are the four type of papilla. So how to identify? Is first say the circumferent papilla. Where it is present? What is this thing? This furrow you could say over. What is this? This is known as sulcus terminalis. Sulcus terminalis. And you know this tongue is developed from foramen sicca. Okay. So still in the adult you will also see there is a remnant of foramen sicca. Okay. And what are these things? There are two things. One is the palatoglossal arch. Okay. Another one is palatopharyngeal arch. Okay. So palatoglossal means it should be connecting with which palate? কোন প্যালেটের সাথে যুক্ত হবে বল? Palatoglossal arch. If you open the oral cavity, here you could see there are two lines are going. One is above, one is below. Right? So from tongue it is going to which palate? Palate কটা আছে আমাদের? How many palates we have? Hard palate and soft palate. So which one is the hard palate? Just above. Okay? Afterwards you will have the soft palate. So this tongue palatoglossal arch should be extending from the this tongue up to the soft palate. Okay? So this is the thing. So the first one is circumferent papilla that will be present over here. Okay? This is also known as phalate papilla. And fungiform papilla and filiform papilla are be present on the apex. Okay? And these are concerned with a different type of taste. Okay? Could be salty, could be sour, anything. So these are responsible for the different type of taste. Okay? So see, these are the papilla they have shown. First one is circumferent papilla. Okay? So you could see it is present throughout, right? On the sulcus terminalis. These are the foliate papilla. These are very small. Foliate papilla means whatever the small thing you could see the ring-like structure. So these are the foliate papilla. Okay? And this is the fungiform papilla. And at the apex there is filiform. These are the. You said anything? What? This follow. It is present.
Which may line.
Lining tongue to ওইভাবে ডেভেলপমেন্ট অফ tongue you study they will to understand. ঠিক আছে কারুর টাঙে কিন্তু ফলো থাকে. It's a congenital anomaly.
Bengali বলছি না.
You could not understand. বাংলা তো কোথায় বললাম ইংলিশে তো বললাম.
এই তো
কারো
কিসে বলবো Okay, now write it down lamina propria. What are the things present on the lamina propria? So first one is the lamina propria contains three type of lingual glands. Okay, there are three type of lingual gland, anterior von Ebner's gland and posterior gland. Okay, so these are the three type of gland. First one is mixed with submucous, and it is present on the tip. So anterior would be present on the anterior surface. Okay, and these von Ebner glands, these are serous in nature and related to the palate and foliate papilla. Related to the, it is MCQ after, okay, von Ebner's gland. So it is present on the serous type and related to the palate and the foliate papilla. Okay, and posterior gland is related to the lingual tonsil. Okay, posterior gland is related to the lingual tonsil. Just now you have seen, okay, on the posterior surface. So dark open into the central crypt. So chance of tonsillitis is nil. কেন লিঙ্গুয়াল টনসিল তো আছে আমাদের, তো সেখানে কেন টনসিলাইটিস হয় না? ওকে, সো দে হ্যাভ এক্সপ্লেইনড why. Okay, because the ducts open into the central crypt. ঠিক আছে, যেটাই হচ্ছে যদি কোনো সিক্রেশন আসে সেটা ওরাল ক্যাভিটিতে মিশে যাচ্ছে। ওকে, ইনফেকশনের চান্স থাকছে। ঠিক আছে, সো চান্স অফ টনসিলাইটিস ইজ nil. So this is about the three type of glands. These are present where? To the lamina propria, first layer. Okay, then the second one is, so see, this is one, they are showing one slide of one part of tongue. Okay, histology of tongue. So you could see this is the basement membrane of lamina propria. So whatever the gland you will get over here. Okay, and it is this is the mucous membrane that is lined by stratified squamous epithelium. And what it is, এটা কি elevation গুলো, which type of it is circumference. Okay, remember the shape. Okay, it is circumferent papilla. যে জায়গায় specimen needs, suppose they have taken on the posterior side, so it will come circumferent. They, if they will take anterior side, the foliate and filiform will come. Okay, so now the mucous membrane. So over the dorsal surface of tongue is rough. Why this dorsal surface is rough? Explanation is presence of the lingual papilla and the lingual tonsil. Okay, papilla জন্য এই সারফেসটা রাফ, কিন্তু যদি ventral surface দেখবি it will be smooth. Okay, whereas the ventral surface is smooth and slippery. Okay, okay, now the dorsal surface. So just now you have seen the dorsal surface is tongue. There is one V-shaped area. So this V-shaped area is known as sulcus sternus. A V-shaped area anterior is known as anterior two-third, posterior is known as posterior two-third. And it will develop from where? The foramen cecum. Point is foramen cecum. Okay. So the dorsal surface is divided into two parts by a V-shaped sulcus sternus. So anterior two-third is the oral part. যেটা oral side আছে, that is known as oral part, and which is present posteriorly, that is known as pharyngeal part. কারণ টাঙের posteriorly কি আছে, এই এরিয়াটা কি বলে, কোন পার্ট থাকে ফ্যারিংসে? ফ্যারিংসটা তো নোজ থেকে নামছে, রাইট, কানেক্টিং নেমে যাচ্ছে, and it would be going where? Up to the larynx. তাই তো, তো যেটা নোজের সাথে অ্যাটাচ সেই ফ্যারিংসের পার্টটাকে কি বলে? Nasopharynx, base of the skull. Then just this oral cavity posterior means just, so that is known as oropharynx. It is a part of digestive tract. Then between the oropharynx and the laryngopharynx, which thing is there? দুটো পার্টিশন থাকে, তাই তো, nasopharynx, nasopharynx, oropharynx, laryngopharynx. So between nasopharynx and oropharynx, which structure is there? I told you, I explained you that so that no food particle could go to the nasopharynx, which will act as a shutter. Soft current. Soft current. Actually, actual answer would be soft current. ওগুলো কি, ওগুলো জাস্ট যখন ওরোফ্যারিংসে তুই দেখছিস পোস্টেরিয়রলি একটা এলিভেশন দেখতে পাচ্ছিস সফট পার্টের নিচে, ঠিক আছে, দিস মাসল ইজ নোন অ্যাজ মাসকুলারিস ইভিউলি। ঠিক আছে, সো অ্যাকচুয়াল অ্যানসার উড বি সফট প্যারেট। between the nasopharynx and oropharynx, and between oropharynx and laryngopharynx is right, that is epipharynx. Okay, so that no food particle again will go to the larynx. Larynx এ গেলে কি হবে, কোন দিকে লাংস যাবে?
একটা পার্ট স্পিড একটা লাইন
বল, এটা তো অলরেডি টট। এগুলো খুব স্পেসিফিক জিনিস। Which bronchus is straight and one in number? Just before 1 month also, এক মাসও হবে না তোকে বলেছি ক্লাসটা। Right bronchus, ঠিক আছে, right bronchus, because it is single in number and it is straight, so that if any foreign particle it will lodge to the right lung. Okay, and on the left side there is two lung, one is epiarterial, another one is hypoarterial lung. Okay, so the anterior 2/3 is the oral part, posterior 1/3 is known as pharyngeal part. So what is lingual tonsil? These are the rounded elevation called lingual tonsil due to the presence of lymphatic nodules into the lamina propria. Okay, so if anybody will ask, okay, appendix is also like that. What is tonsil? What is the definition of tonsil? Tonsil জিনিসটা কি? হ্যাঁ বল। খানিক তো partially correct. Okay, it is the aggregation of lymphatic follicles. Okay, these are the aggregation of lymphatic follicles. Okay, so whenever there is any kind of infection due to immunity, the infection will infect which thing? That is the tonsil. Tonsil is the first thing to infect. Suppose your abdomen e kichu hoyeche, abdominal problem, first thing to infect is appendix. Okay, so that's why it is known as abdominal tonsil. Okay, and which is known as abdominal watchman? Greater omentum. Whenever there is any infection ulcer, it will go and cover that particular area. Okay, particularly present on the stomach. Okay, so see, irregular numerous type of projection present on the tongue. So this is already we have discussed. There are 4 type of papilla: circumferent, fungiform, piliform, and foveal. Okay, these are the 4 type of papilla. So one by one we will go to what is the histological structure. Okay, so number 1 is piliform. So you have seen it is the smallest pinpoint papilla. Okay, epithelium is keratinized. Epithelium is keratinized. So that's why that area is rough. যেখানে keratin আছে সেই জায়গাটা টাফ হবে। Okay, then sharply pointed. Next is small and conical in shape, no taste bud. এখানে কিন্তু কোনো taste bud থাকে না। Okay, so these also comes as MCQ. Okay, there is no taste bud. Okay, so smallest papilla, epithelium is keratinized, sharply pointed, small and conical in shape, and there is no taste bud. So that is piliform papilla. Okay, so see, this is they are showing piliform papilla. So where you could get, so this is present over here. You could say they are present in numerous in numbers. Okay, and you could also see there is one type of gland that is known as serous gland, that is known as von Ebner's gland. Okay, von Ebner's gland. And what are the taste bud? Taste bud would be present where? Specifically at the circumvallate papilla. Specifically present on the circumvallate papilla. Okay. Next one is fungiform. So why it is called fungus? Because it is mushroom-like. Okay, histological feature is it is looking like a mushroom, and it is broader, larger, taller, and club shape. Broader, larger, and taller, and it is club shape. Okay, and it is non-keratinized. And where it is present? Just in between the piliform papilla. In between the piliform papilla. Okay. So mushroom-like border, larger, taller, club shape, non-keratinized, occurs in the space between piliform papilla. So that is fungiform papilla. So we will see the how does it look like. Okay. Then next one is circumvallate papilla. So this is the, remember, largest papilla. Largest papilla is circumvallate. Okay. Anterior to the sulcus terminalis. যদি বলে exact where is the location, Hereditary papilla হচ্ছে largest papilla anterior to the sulcus terminalis, okay, least in number. How many? Remember, only 8 to 12. 8 to 12. So they are present just anterior to the sulcus terminalis. যে V shape area আছে, just anterior you will get this circumhereditary papilla, and it is seen, okay, 8 to 12 in number. So circumhereditary papilla is characterized by deep furrows or moles. So you have seen how it is looking like club shape, okay? And serous bone-egners gland or leucine gland empty their serous secretion into the base of the furrow. Okay, so this furrow is like that base of the furrow. Which thing is secreted? The secretion from the bone-egners gland. Okay, and I told it is a type of serous gland. Okay, and numerous taste buds are present. Okay. So what is foliate papilla? It is purely developed in humans. Okay, it is purely developed in humans. If present, found along the posterior and lateral border of the tongue. যদি পাওয়াও যায় কোথায় পাওয়া যাবে? On the posterior and the lateral border. Okay. So according to the papilla, the taste would be changed. Clearly, anterior কোন টেস্টটা বেশি হবে? Have you checked? Have you noticed? The salty or sour, it would be found on the circumhereditary. Okay, and the sugary would be on the lateral side. Okay, so it vary according to the papilla. Okay, so taste bud, how does it look like? Suppose if you are seeing one taste bud below the microscope, so how does it appear? First one is barrel-shaped bodies. So these are the barrel-shaped bodies embedded within the epithelium of papilla except the filiform papilla. So I told you what is the example of no taste bud, means absence of taste bud, that is filiform, pointed one. This much small, so how the taste bud could be present over there? Okay, so just remember this one. So these are the barrel-shaped body embedded within the epithelium of papilla except the filiform papilla. Okay, so types of cells are sustentacular or supporting cells and taste or gustatory cells. These are the basal cells. Taste pore, opening of bud into the surface. Okay, so these are the numerous type of cells that are present in the taste bud. If you remember, that's okay. Okay, these are the cells like sustentacular, supporting, taste or gustatory, basal cells, and there are some taste pores. Taste pore to থাকতে হবে from where this taste sensation would be taken out. Okay, so these are the taste pores. Okay, so on the posterior part, already we told, has numerous lymphatic tissues and there is a presence of lingual toxin. Okay, and remember it is non-keratinized, absence of filiform honeycomb. To see this thing one by one, they have described. So first one is filiform. So filiform is keratinized stratified squamous epithelium. Filiform is rough, pointed, so it will be keratinized. Okay, and where it will be seated on the above the tongue, surface of the dorsal surface. Okay, then fungiform, you could see it is looking like a mushroom, right? So fungiform is stratified squamous epithelium again, and you could also see some vasculature over there. And circumhereditary, how does it will appear? There is presence of furrow, there is a presence of bone-egners cells on the base. Okay, so this is the circumhereditary papilla, and these are the taste bud. So where it could be located, you could see this furrow in between that. There is the presence of taste buds. Okay, so how does the taste bud look? It is looking like a barrel. Okay. So this is as a whole what you have to write, the histological features. Okay. So first one is fungiform filiform papilla. You have to write these are the conical filiform papilla with no taste bud. Then mushroom shaped fungiform papilla covered with stratified squamous epithelium and skeletal muscle running in different directions. So these 4 points you have to mention if you got the slide of tongue. Okay. These are the, write it down, these are the histological features. Okay. এটা তোরা একটা টোটাল যতগুলো হিস্টোলজিক্যাল পার্ট ছোট একটা ওই হোয়াইট কালারে দেখবি শুধু ইয়ে পাওয়া যায় ডায়েরি টাইপের ওয়্যার দিয়ে করা ওকে স্পাইরাল যেগুলো ওগুলো তো প্রতিটার একটা একটা করে স্লাইড ওটা কি হবে এক্সামের আগে শুরু হবে ঠিক আছে কারণ 10টা থেকে 15টা স্লাইড ইউ উইল ডিসাইড একটা ফাইনাল ওটা ভুল হলে সব হিস্টোলজি গেল জিরো পেয়েছে অনেকে আর অনেকে 9 পেয়েছে কমে যাবে তো নাম্বার সেটা আই হাউ টু এক্সে হ্যাঁ
মার্কস কত থাকে?
ফাইনালে বলছি প্রফেশনাল
হিস্টোলজিতে মার্কসের বেড়েছে
5 কিন্তু 10 নাম্বার and 2 marks each slide 5টা slide তার হিস্টোলজিক্যাল ফিচার মানে একটাও যদি ভুল হয় সেখানে তুই সেই মার্কসে 0 হয়ে যাবে identification is the main point whether you write or don't write you don't know it is wrong then অনেক ভালো ভালো ছেলেগুলো গত বছর পড়ে খারাপ ঠিক আছে সুতরাং হিস্টোলজি ইউ হ্যাভ টু ভেরি কেয়ারফুল
এতগুলো আছে
লাস্টে বলতে দেবে খানিকটা হয়তো তুই বলে দিল যে ঠিক আছে এগুলো কতগুলো করো কিন্তু সেইগুলোর মধ্যেই ওটা সেই জন্য আমি বলছি এখন থেকে ওটা একটু you could revise also okay each and every semester whatever slide is over you take 1 day to just revise come and revise ठीक है microscope lagi just like anything else okay so this is see this picture is quite clear so you could see these are the different type of glands and where is the taste part is present just between the circumference membrane okay so which is the taste part this is the taste part okay not this furrow just beside the circle okay and this is lining epithelium is striatic muscle so it will be appear how it will be appear with eosin state okay so it will be appear on island okay this is the filium papilla individually if you see how does it look like okay so this thing again they have shown one by one so circumferent papilla I don't know here they have differentiated the papilla or not but you will get one slide as a tongue overall okay then you have to mention all the histological features okay so what is this এটা কিন্তু একটা শর্ট নোট অনেক সময় আসে what is taste part ঠিক আছে taste part এর কি কি স্ট্রাকচার okay so I told you there are different type of cells প্রথমে কি থাকে basal cells you know this is the type of sensation so receptor cell would be there supporting cell that is the sustentacular cells and there would be gustatory pores okay taste part এর একটা ছোট short note হয় please study that one okay what is taste part and what are the characteristics okay so what is clinical anatomy clinical anatomy why we are studying histology not tongue as a whole okay histology কেন পড়ছি because we know for the carcinoma of tongue it is very common ঠিক আছে oropharyngeal carcinoma smoking এ হয় anything এ cause করতে পারে ঠিক আছে oropharyngeal specifically the monosodium glutamate কি হলো কে smoke so that may cause the carcinoma of tongue ঠিক আছে oropharyngeal carcinoma another why we are studying for radiotherapy and surgery okay so this is pathology তে গিয়ে কিন্তু tongue carcinoma slide পাবে okay so at that time you see the cells has been differentiated what is the definition of carcinoma of cancer
abnormal division of abnormal division
undifferentiated abnormal cell division with the involvement of basement last point যদি না দিস definition is zero okay with the involvement of basement অবশ্যই basement membrane কে okay and unexpected and undifferentiated cell so that is about the carcinoma okay now we go and see the